Hello everyone, and welcome to another chapter of Advanced Pharmacology. Today we're talking about chapter 46, Drugs for Diabetes Mellitus. Diabetes mellitus, some basic considerations. The term diabetes mellitus is derived from the Greek word for fountain and the Latin word for honey. The term describes one of the prominent symptoms of untreated diabetes, production of large volumes of glucose-rich urine. Indeed, long ago, the disease we now call diabetes was diagnosed by the sweet smell of urine, and yes, by its sweet taste as well. In this chapter, we use the term diabetes mellitus and diabetes interchangeably. Diabetes is primarily a disorder of a carbohydrate metabolism. Symptoms mainly result from the deficiency of insulin or from cellular resistance to insulin's action. The principal signs of diabetes is sustained hyperglycemia, which results from impaired glucose uptake by cells and from increased glucose production. When hyperglycemia develops, it can quickly lead to polyuria, polydipsia, ketonuria, and weight loss. Over time, hyperglycemia can lead to heart disease, renal failure, blindness, neuropathy, amputations, impotence, and even strokes. There is an often overlooked point about diabetes. In addition to affecting carbohydrate metabolism, insulin deficiency disruption metabolism of proteins and lipids. We refer to the regulation of blood glucose levels as glycemic control. In the US, diabetes is the most common endocrine disorder and the seventh leading cause of death by disease, according to the 2011 National Diabetes Fact Sheet compiled by the Center for Disease Control and Prevention. About 26 million Americans have diabetes, and nearly one-fourth of them have not been diagnosed. Another 79 million or so Americans are estimated to have prediabetes and are at an increased risk for developing diabetes in the future. We need to do a better job at diagnosing diabetes and treating it, and we need to do what we can to reduce the risk for developing the disease in the first place. Unfortunately, the risk for developing diabetes is largely genetic, a factor that we simply can't modify. Nonetheless, we can still reduce risk significantly by adopting a health lifestyle centered on emerging on both physical activity and establishing a healthy diet. So there's different types of diabetes mellitus. There are two main forms of diabetes, type 1 and type 2. Both forms have similar signs and symptoms. Major differences, however, concern etiology, their prevalence, treatment, and overall outcome. The distinguishing characteristics of type 1 and type 2 diabetes are shown in the following table 46.1 and are discussed further later. Another important form, gestational diabetes, which is discussed later under the diabetes and pregnancy. Although there are additional forms of diabetes, they are relatively rare and will not be discussed specifically here. So here was that table that they were talking about a moment ago, the characteristics of both type 1 and type 2 diabetes. So if you're not overly familiar with your pathophysiology and your regular signs and symptoms, here is a good spot to hit pause and review those. Type 1 diabetes. Type 1 diabetes accounts for about 5% of all diabetes cases. Between 1.2 and 2.4 million Americans have this disorder. In the past, type 1 diabetes was called juvenile onset diabetes mellitus or insulin-dependent diabetes mellitus. These terms have fallen out of favor, however, because type 2 diabetes is becoming a lot more common in children, and many people with type 2 diabetes use insulin to manage their diabetes. Accordingly, the terms juvenile onset diabetes mellitus and IDDM are no longer clinically useful. Generally, type 1 diabetes develops during childhood or adolescence, and symptom onset is relatively abrupt. That being said, type 1 diabetes can develop during adulthood as well. The primary defect in type 1 diabetes is the destruction of pancreatic beta cells, the cells responsible for insulin synthesis and the release into the bloodstream. Insulin levels are reduced early in the disease and usually fall to zero later. Beta cell destruction is the result of an autoimmune process. The patient's immune system inappropriately wages war against its own beta cells. The trigger for this immune response is not entirely known, but genetic, environmental, and infectious factors all play a potential role. Which brings us to type 2 diabetes. Type 2 diabetes is the most prevalent form of diabetes, accounting for 90% to 95% of all diagnosed cases. Roughly 22 million Americans have this disease. In the past, type 2 diabetes was called non-insulin dependent diabetes, or adult onset diabetes mellitus. As discussed previously for type 1 diabetes, these terms are no longer clinically useful, again because insulin is becoming commonly more used with people with type 2 diabetes. And again, type 2 diabetes can occur in all age groups. The disease most commonly begins in middle age and progresses gradually. In contrast to type 1 diabetes, type 2 diabetes carries little risk for ketoacidosis. However, type 2 diabetes does carry the same long-term risk as type 1 diabetes. Symptoms of type 2 diabetes usually result from a combination of insulin resistance and an impaired insulin secretion. In contrast to patients with type 1 diabetes, those with type 2 diabetes aren't capable of insulin synthesis. In fact, early in the disease, insulin levels tend to be normal or slightly elevated, a state known as hyperinsulinemia. However, although insulin is still produced, its secretion is no longer tightly coupled to plasma glucose content. Release of insulin is delayed and peak output is subnormal. More important, the target tissue of the insulin, the liver, muscles, adipose tissue, exhibit insulin resistance for a given blood insulin level. Cells in these tissues are less able to take up and metabolize the glucose available to them. Insulin resistance appears to result from three major causes: the reduced binding of insulin to its receptors, reduced receptor numbers, and reduced receptor responsiveness. Over time, hyperglycemia leads to diminished pancreatic beta cell function, and hence insulin production and secretion eventually decline as the beta cells work harder to overcome insulin resistance within these tissues. Although the underlying cause of type 2 diabetes are not entirely known, there is a strong familial association, suggesting that genetics play a role. This possibility was reinforced by a study that implicated the gene for insulin receptor substrates, a compound that helps mediate intracellular responses to insulin. So, diabetes and pregnancy. Before the discovery of insulin, virtually all babies born to mothers with severe diabetes died during infancy. Although insulin therapy has greatly improved outcomes, successful management of a diabetic pregnancy remains a challenge. Three factors contribute to the problem. First, the placenta produces hormones that antagonizes insulin's actions. Second, the production of cortisol, a hormone that promotes hyperglycemia, increases threefold during pregnancy. Both of these factors increase the body's need for insulin. The third, because glucose can pass freely from the maternal circulation to the fetal circulation, hyperglycemia in the mother will stimulate excessive secretion of insulin in the fetus. The resultant hyperinsulinism can have multiple adverse effects on the fetus. Successful management of diabetes during pregnancy demands that proper glucose levels be maintained in both the mother and the fetus. Failure to do so may be teratogenic and may have otherwise harm to the fetus. Achieving glucose control requires diligence on the part of the mother and her prescriber. Some experts on diabetes and pregnancy advise that glucose levels must be monitored 6 to 7 times a day. Insulin dosage and food intake must be adjusted accordingly. Gestational diabetes is defined as diabetes that appears in the pregnant patient during pregnancy and then subsides rapidly after delivery. Gestational diabetes is managed in much the same manner as any other diabetic pregnancy. Blood glucose should be monitored and then controlled with diet and insulin. In most cases, the diabetic state disappears almost immediately after delivery, permitting discontinuation of insulin. However, if the diabetic state persists beyond parturition, it is no longer considered gestational and should be re-diagnosed and treated accordingly. In women taking an oral drug for type 2 diabetes, current practice is to discontinue the oral drug and switch over to insulin. The only exception is the oral agent metformin, which is often satisfactory for managing type 2 diabetes in pregnant women. Women who discontinue oral medications can resume oral therapy after delivery. So, its diagnosis. Diagnosis of diabetes was once made solely by measuring blood levels of glucose. However, in 2010, the American Diabetes Association recommended an alternative test based on measuring hemoglobin A1C, a test that provides an estimate of glycemic control over the previous 2 to 3 months. For all of these tests, diagnostic values of diabetes are shown on Table 46.2. So here is that criteria for the diagnosis of diabetes. A good spot to pause if you're unfamiliar. Other tests on blood levels of glucose. Excessive plasma glucose is a diagnostic of diabetes. Several tests may be employed, including a fasting plasma glucose, a casual plasma glucose test, and an oral glucose test. To make a definitive diagnosis, however, the patient must be tested on 2 separate days, and both tests must be positive. Any combination of the 2 tests can be used. So, we'll start with the fasting plasma glucose test. To determine an FPG, blood is drawn at least 8 hours after the last meal. In a normal glycemic individual, your fasting plasma glucose is usually less than 100. If the FPG glucose levels is 126 or higher, diabetes is present. On a casual plasma glucose test. For this test, blood can be drawn at any time, without regard to any meal. Fasting isn't required, and of note, the test can be performed in office, using a fingerstick blood sample and the same type of test device employed by patients at home. A plasma glucose level that is 200 or higher suggests diabetes. However, to make a definitive diagnosis, the patient must also display classic signs of diabetes, so polyuria, polydipsia, and rapid weight loss. Ketonuria may also be present, but only if the blood glucose is extremely high. And the last one here, the oral glucose tolerance test. This test is often used when diabetes is suspected but could not be definitively diagnosed by measuring a fasting or a casual plasma glucose level. The oral glucose tolerance test, or OGTT, is performed by giving an oral glucose load and measuring plasma glucose levels 2 hours later. In individuals who do not have diabetes, 2 hours glucose levels will be below 140. Diabetes is suggested if 2-hour plasma glucose levels are 200 or higher. The OGTT test is more expensive and time-consuming than the alternative and is not used routinely. One of the times that you will see this test being given is if you're pregnant and they're testing you for gestational diabetes. Which brings us to one of the blood tests, your hemoglobin A1C. Again, as described later, or as it will be described later, monitoring treatment, levels of a hemoglobin A1C, or simply A1C, reflects average blood glucose levels over the previous 2 to 3 months. Accordingly, if a patient's A1C is high, we know that his or her glucose levels have been high for a relatively long time. In other words, we know that he or she has diabetes. An A1C value of 6.5 or higher is considered diagnostic. It's important to note that the A1C test is not necessarily accurate in all patients because some people have conditions that can affect a hemoglobin level, thus skewing the results of this test. Among these are pregnancy, chronic kidney or liver disease, recent severe bleeding or blood transfusion, and certain blood disorders, including thalassemia, iron deficiency anemia, and anemia related to a vitamin B deficiency. So, your increased risk for diabetes or prediabetes. The increased risk for diabetes, also referred to as prediabetes, is a state defined by impairing fasting plasma glucose. That's your FPG between 100 and 125, or an impaired glucose tolerance, that 2-hour OGTT result of 140 to 199. These values are below those that are defined diabetes, but are still too high to be considered normal. So, people with prediabetes are at an increased risk for developing type 2 diabetes and cardiovascular disease, but not the microvascular complications associated with diabetes. So, your retinopathies, your neuropathies, or neuropathy, or nephropathy. The risk for your cardiovascular disease can be reduced by simple dietary modifications, increased physical activity, and, if indicated, the use of appropriate drugs to control blood lipids and blood pressure. The risk for progression to diabetes may be reduced by diet and exercise, and possibly by certain oral anti-diabetic drugs, such as metformin. It's important to note that many people who meet the criteria for prediabetes actually never go on to develop diabetes. And even if they don't modify their lifestyle, and even if they don't take anti-diabetic drugs, hence, although prediabetes indicates an increased risk for diabetes, it's by no means a guarantee that diabetes will actually occur. So, let's take a look at the overview of treatment, therefore. The primary goal of treatment type 1 or type 2 diabetes is the prevention of long-term complications. To minimize these complications, treatment must keep glucose levels as close to normal and as safely possible. In addition, treatment must keep blood pressure and blood lipids within an acceptable range. In both type 1 and type 2 diabetes, proper diet and adequate physical activity are central components of this management. So, we'll look at type 1 diabetes. Preventing complications of diabetes requires a comprehensive plan directed at glycemic control and the reduction of cardiovascular risk factors. Glycemic control is accomplished with an integrated program of diet, self-monitoring of blood glucose, physical activity, and insulin replacement. Of importance, glycemic control must be achieved safely, that is, adequate control in glycemia while minimizing the risk for hypoglycemia. An essential component of treatment, education of the patient and his or her caregivers about diet, physical activity, and drugs. It's usually left to the nurse and the dietitian or nutritionist to give that education. Your dietary measures. Proper diet, a balanced by insulin replacement, is the cornerstone of treatment. Because patients with type 1 diabetes are usually thin, the dietary goal is to maintain weight and not lose it. The ADA recommends that all people with type 1 diabetes be offered intensive insulin therapy education using either a carbohydrate counting or experience-based estimation approach in achieving glycemic control. Although it is widely accepted that such programs are useful for people with type 1 diabetes, studies examining the ideal amount of carbohydrates are largely inconclusive. So, how should people with diabetes be advised to eat? Evidence suggests that there is no ideal percentage of calories that should be ingested from carbohydrate, fat, or protein. Accordingly, a macronutrient distribution for any given individual should be based on his or her current eating patterns, preferences, and goals. Physical activity. Unless specifically contraindicated, regular physical activity should be part of the management program. Physical activity increases cellular responsiveness to insulin and may also increase glucose tolerance. Accordingly, the ADA recommends that patients perform at least 150 minutes of moderate intensity aerobic activity per week. Because strenuous exercise can produce hypoglycemia, patient and provider must work to establish a safe balance between activity level, caloric intake, and insulin dosage. Unfortunately, although the benefits of physical activity are well established, long-term adherence to a program is often difficult to maintain. Insulin replacement. Among patients with type 1 diabetes, survival requires daily dosing with insulin. Before insulin replacement became available, people with type 1 diabetes invariably died within a few years after disease onset. The cause of death was usually ketoacidosis. It is essential to coordinate insulin dosage with carbohydrate intake. If carbohydrate intake is too great or too small with respect to insulin dosage, hyperglycemia or hypoglycemia will eventually result. Although insulin is the cornerstone to the management of type 1 diabetes, the use of other medications as add-on therapy to insulin is currently under study. Managing the hypertension and dyslipidemia. An angiotensin-converting enzyme inhibitor, such as lisinopril, or an angiotensin II receptor blocker, an ARB, such as losartan, can reduce the risk for diabetic nephropathy, a long-term consequence of poor glycemic control. These same drugs are preferred agents for managing diabetic hypertension. The current goal, as set by the ADA, is to keep blood pressure at or below 140/90, with lower systolic blood pressure targets less than 140, appropriate for some individuals. To reduce high levels of low-density lipoproteins, your cholesterol, statins are your preferred drug choice. So your atorvastatin, for instance. Not only do statins reduce cardiovascular events in patients with high cholesterol, they reduce cardiovascular events in patients with normal or low cholesterol. Another cholesterol-lowering drug, uracil, is discussed separately later because it is recognized in its role in managing diabetes. So we'll discuss that more in chapter 42. Type 2 diabetes. As with type 1 diabetes, the prevention of long-term complications requires a comprehensive treatment plan. Again, lifestyle measures, your diet and physical activity, and drug therapy are the foundation of glycemic control. Physical activity provides the additional benefit of promoting glucose uptake by muscles, even when insulin levels are considered low. In addition to the glycemic control, the plan should address other factors that can increase morbidity and mortality. Accordingly, all patients should be screened and treated for hypertension, nephropathy, retinopathy, and neuropathy. In addition, dyslipidemias, again that high LDL cholesterol, and low high-density lipoproteins, your HDL cholesterol, and triglycerides, should be corrected. Recommendations for glycemic control have changed. Until recently, treatment was started with lifestyle measures alone. Drugs were added only if these measures started to fail. Today, treatment is started with lifestyle measures plus drug therapy. We no longer wait for the use of drugs. As a result, glycemic control is established sooner, and the risk for long-term complications is lowered. Your type 2 diabetes can be treated with a variety of oral and injectable drugs. Among the oral drugs, metformin and the sulfonylureas, such as your glipizide, are used most widely. Among the injectable drugs, insulin is used most widely. As type 2 diabetes progresses, less and less insulin is produced. As a result, it is common for people with type 2 diabetes to eventually require insulin therapy. Given the many drugs available for type 2 diabetes, how does one decide which drug to use for a given patient? As discussed in a 2015 position statement update, the management of hyperglycemia in type 2 diabetes, a patient-centered care approach, issued jointly by the ADA and the European Association for the Study of Diabetes. There are a number of patient-specific considerations that come into play when deciding on a course of treatment to treat a type 2 diabetic. The position statement recommends a four-step approach. So, step 1. At diagnosis, initiate lifestyle changes, including the addition of the medication metformin. Step 2. Continue lifestyle changes plus metformin and add a second drug, either your sulfonylurea, a thiazolidinedine, a dipeptidyl peptidase 4 inhibitor, a sodium glucose cotransporter inhibitor, a glucagon-like peptide 1 receptor agonist, or simply basal insulin. The choice of agent is made in light of relative efficiency or efficacy, hypoglycemia risk, tolerability, weight-related considerations, and overall the cost. Step 3. Progress from Step 2 to a 3-drug combination, inclusive of metformin. Again, the choice of regimen is used to determine based on drug and patient-specific considerations. And lastly, Step 4. If the 3-drug combination therapy that includes basal insulin fails to achieve treatment goals after 3 to 6 months, it is recommended to proceed to a more complex insulin regimen, usually in combination with one or more non-insulin medications. Treatment should always start at Step 1 and then progress through Steps 2, 3, and then 4 if needed. You shouldn't need to skip steps in order to get proper treatment or proper care. Determining appropriate glycemic goals. In both your type 1 and type 2 diabetes, it is important to determine appropriate glycemic goals for the individual based on his or her lifestyle and other patient-specific considerations. The process of maintaining glucose levels within normal range around the clock is often referred to as tight glycemic control. Maintaining tight glycemic control is difficult, but can be worth the trouble, especially for young patients with type 1 diabetes. However, many patients with type 2 diabetes, the risk of tight control may be greater than the benefits. So, Table 46.3 shows the current recommendations regarding glycemic control. So, here is a good spot to take a look at that. So, jumping back to type 1 diabetes, the benefits. The benefits of tight glycemic control in a type 1 diabetes were demonstrated conclusively in the Diabetes Control and Complications trial, in which a patient received either a conventional insulin therapy or intensive insulin therapy. After 6.5 years, patients who received intensive therapy experienced a 50% decrease in clinically significant kidney disease, a 35 to 57% decrease in neuropathy, and 76% decrease in serious ophthalmic complications. Moreover, onset of ophthalmic problems was delayed, and the progression of existing problems was slowed. In addition to reducing these microvascular complications, tight control decreased macrovascular complications. A 17-year follow-up data from the DCCT showed a significant reduction in myocardial infarction, coronary revascularization, and angina. Therefore, with rigorous control of blood glucose, the high degree of morbidity and mortality traditionally associated with a type 1 diabetes can be markedly reduced. However, there are drawbacks. The greatest concern for intense therapy and strict glycemic control is hypoglycemia. Because glucose levels are kept relatively low, even a modest overdose with insulin can cause blood glucose levels to fall too low, so the possibility of a hypoglycemia increases. Also, A meal that is skipped or exercise that is too strenuous can do the same thing. Results of the DCCT showed that compared with patients using a conventional therapy, those using the intensive insulin therapy experienced 3 times as many hypoglycemic events, requiring the assistance of another person, and 3 times as many episodes of hypoglycemia-induced coma or seizures. In addition, patients on intensive insulin therapy experienced greater weight gain, about 10 pounds on average. Other disadvantages are the greater inconvenience, increased complexity, and the need for greater patient motivation. Finally, the cost was much higher. Whereas traditional therapy costs about $1,700 a year, intense, intensive therapy costs upwards of $4,000 a year, or $5,800 if a continuous infusion with an insulin pump is utilized. The cost of these test strips for the patient's glucometer adds substantially more to the bill. Bringing us to type 2 diabetes. In patients with type 2 diabetes, benefits of tight glycemic control are limited mainly to microvascular complications. Tight control does little to reduce macrovascular complications, as evidenced by studies performed to date. Furthermore, benefits accrue more to younger adults with recent onset disease than to other adults or older adults with well-established disease. As in type 1 diabetes, tight glycemic control poses a significant risk for hypoglycemia and weight gain. In addition, tight control may increase the risk for death. The effects of tight glycemic control in type 2 diabetes were demonstrated in 4 landmark trials, both or starting in the United Kingdom, the prospective diabetes studies, the action to control cardiovascular risk in diabetes, action in diabetes and vascular disease, and Veterans Affairs diabetes trials. These large randomized trials differed in patient populations, whereas the UK PDS trial enrolled younger adults with recent onset diabetes and no prior cardiovascular events. The Accord, Advance, and VADT trials enrolled older adults with long-standing diabetes, as well as established cardiovascular disease or risk factors. The results of the UK PDS trial, released in 1999, showed a significant reduction in microvascular complications, but little or no reduction in the macrovascular complications or death. In one branch of the study, non-obese patients were given either intensive therapy or conventional therapy. Mean values for the A1C were 7% in the intensive group and 7.9% in the conventional group. Compared with patients in the conventional group, patients in the intensive group had a 12% reduction in total diabetes-related endpoints, meaning cardiovascular, retinal, or renal damage. However, a reduction in microvascular complications accounted for the most of the benefit. Results of the Accord, Advance, and VADT were released back in 2008. As in the UK PDS trial, tight glycemic control failed to reduce stroke, amputations, and all-cause mortality, or mortality from cardiovascular disease. In fact, in these Accord trials, intensive therapy was associated with an increased risk for death. Tight control also increased the risk for severe hypoglycemia and weight gain. The Advance trial did show a reduction in microvascular outcomes, but the Accord trial did not. Taken together, these 4 studies suggest that tight glycemic control is most appropriate for younger adults who have recent onset of type 2 diabetes and no other cardiovascular complications. Because even short periods of hyperglycemia may risk or increase the risk for complications, optimal therapy should be started as soon as diabetes is diagnosed. So, who should not receive intensive therapy, therefore? Patients with long-standing type 2 diabetes, advanced microvascular or macrovascular complications, patients with extensive comorbid conditions, patients with a history of severe hypoglycemia, and patients with a limited life expectancy. For these patients, an A1C goal of 7% may be appropriate than a goal below 7%. So, monitoring and treatment. We need to monitor to determine whether glucose levels are being maintained in a safe range, both in the short term and long term, and guide changes in treatment when the range is not satisfactory or safe. Your SMBG levels are the standard method for day-to-day monitoring. As mentioned previously, that A1C is measured to assess the long-term glycemic control. So, when we're talking about SMBG, we're talking about self-monitoring of blood glucose, which is recommended for all patients who use insulin. That is, SMBG is recommended for all patients with type 1 diabetes and for all patients with type 2 diabetes who are receiving insulin. And it is additionally used by most patients with type 2 diabetes using other therapies as well. Information on blood glucose concentration provides a guide for fine-tuning dosages of insulin and other anti-diabetic drugs. The frequency of SMBG for any given patient can vary widely based on the therapies the patient uses and how active he or she is. A patient on metformin, the monotherapy, may only need to check his or her blood sugar once per week, whereas a patient with type 1 diabetes on an intense insulin regimen may check it up to 8 times per day or more. Frequently used target values for blood glucose are 70 to 130 before meals and 100 to 140 at bedtime. So the monitoring of that hemoglobin A1C. Measurement of hemoglobin A1C, also called the glycosylated hemoglobin or glycated hemoglobin, provides an index of average glucose levels over the prior 2 to 3 months. Glucose interacts spontaneously with hemoglobin and red blood cells to form glycosylated derivatives, the most prevalent being A1C. With prolonged hyperglycemia, levels of A1C gradually increase. Because red blood cells have a long lifespan of 120 days, levels of A1C reflect average glucose levels over an extended time. Therefore, by measuring A1C every 3 to 6 months, we can get a picture of long-term glycemic control. Please note, however, that measuring A1C tells us nothing about the acute hour-to-hour swings in blood glucose. Accordingly, although measuring A1C is an important part of diabetes management, it is clearly no substitute for the SMBG. Results are usually reported as a percent of total hemoglobin in blood. In addition, they may be reported as a value for the estimated average glucose, expressed as milligrams of glucose per deciliter of blood. Selected A1C values and their EAG equivalents are shown in the following table. So again, here's a good spot to hit pause so you can familiarize yourself. The general goal is to keep the A1C below 7%. Although an A1C goal of below 7% is good for most patients, a less stringent goal is below 8%, may be more appropriate for some patients, such as those with a history of severe hypoglycemia, a limited life expectancy, or advanced microvascular or macrovascular complications. According to a 2014 statement issued jointly by the ADA and the European Association for the Study of Diabetes, A1C should be measured every 3 months until the value drops to 7%, or at least every 6 months thereafter. As noted previously, a value of 6.5% or greater is considered diagnostic of diabetes. Which brings us now to the prototype drugs for diabetes. Your insulin preparations, then your biguanide, your sulfonylurea, meglitinide, thiazolidinide diones, your alpha-glucosidase inhibitors, gliptin, sodium glucose cotransporter 2 inhibitors, and lastly, incretin. So, let's start off with insulin. Insulin is used to treat all patients with type 1 diabetes and many patients with type 2. Our discussion of insulin is divided into three sections: the physiology, its preparation and administration, and finally the therapeutic use. So we'll start off with the physiology, its structure. The structure of insulin is shown in the following figure. As indicated, insulin consists of two amino acid chains, the A acidic chain and the B the basic chain. The A and B chains are linked to each other by two disulfide bridges. So here is a good spot to hit pause so you can take a look at that insulin. The conversion of proinsulin to insulin. Its biosynthesis. Insulin is synthesized in the pancreas by beta cells within the islet of Langerhans. The immediate precursor of insulin is called proinsulin. Proinsulin consists of insulin itself plus a peptide loop that runs from the A chain to the B chain. This loop is named the connecting peptide or C-peptide. In the final step of insulin synthesis, C-peptide is enzymatically clipped from the proinsulin molecule. Measurement of plasma C-peptide levels offers a way to assess residual capacity for insulin synthesis. Because commercial insulin preparations lack C-peptide, and because endogenous C-peptide is only present as a byproduct of insulin biosynthesis, the presence of C-peptide in the blood indicates the pancreas is still producing some insulin of its own. So its secretion. The principal stimulus for insulin release is a rise in blood glucose, and the most common cause of glucose elevation is eating a meal, especially one rich in carbohydrates. Under normal conditions, there is tight coupling between rising levels of blood glucose and the increased secretion of insulin. Insulin release may also be triggered by amino acids, fatty acids, ketone bodies, and gut hormones, such as your GLP-1. The sympathetic nervous system provides additional control of release. Activation of beta-2-adrenergic receptors in the pancreas promotes the secretion of insulin. Conversely, activation of an alpha-adrenergic receptor in the pancreas inhibits insulin release. Of the two modes of regulation, activation of the beta receptors is more important, leading us to metabolic actions. The metabolic actions of insulin are primarily anabolic or constructive. Insulin promotes conservation of energy and the buildup of energy stores such as glycogen. The hormone also promotes cell growth and division. Insulin acts in two ways to promote anabolic effects. First, it stimulates cellular transport of glucose, amino acids, nucleotides, and potassium. Second, insulin promotes the synthesis of complex organic molecules. Under the influence of insulin and other factors, glucose is converted into glycogen, amino acids are assembled into proteins, and fatty acids are incorporated into triglycerides. The principal metabolic actions of insulin are shown here in the following table. Again, a good spot to hit pause so you can see the metabolic actions of insulin. Metabolic consequences of an insulin deficiency. Insulin deficiency puts the body into a catabolic mode. Hence, in the absence of insulin, glycogen is converted into glucose. Proteins are degraded into amino acids, and fats are converted into glycerol and free fatty acids. These catabolic effects contribute to the signs and symptoms of diabetes. Note that the catabolic effects resulting from insulin deficiency are opposite to the anabolic effects when insulin levels are normal. Insulin deficiency promotes hyperglycemia by three mechanisms: increased glycogenolysis, increased gluconeogenesis, and reduced glucose utilization. Glycogenolysis, by definition, generates free glucose by breaking down glycogen. The raw material that allow increased gluconeogenesis are the amino acids and fatty acids produced by metabolic breakdown of proteins and fats. Reduced glucose utilization occurs because insulin deficiency decreases cellular uptake of glucose and decreased conversion of glucose to glycogen. Its preparations and administration. There are many insulin preparations or formulations. Major differences concern time course, appearance, it's clear or cloudy, concentration, and the route of administration. Because of these differences, insulin preparations cannot be used interchangeably. In fact, if a patient is given the wrong preparation, the consequences can be dire. Unfortunately, medication errors with insulin remain all too common, which explains why insulin appears on all lists of high alert agents. Sources of insulin. All forms of insulin currently manufactured in the US are produced by using a recombinant DNA technology. Some products, referred to as human insulin, are identical to insulin produced by human pancreas. Other products, referred to as human insulin analogs, are modified forms of human insulin. The analogs have the same pharmacologic action as human insulin, but have a different time course. So types of insulin. There's 7 types of insulin. Natural insulin, also known as regular insulin or native insulin, and 6 modified insulins. 3 of the modified insulins, your Lispro, Aspart, and Glulisine, act more rapidly than regular insulin, but have a shorter duration of action. The other modified insulins act more slowly than regular insulin, but have a longer duration. 2 processes are used to prolong insulin's effect: complexing natural insulin with a protein and altering the insulin molecule itself. When the insulin molecule has been altered, we refer to the product as a human insulin analog. When classified according to the time course, insulin preparations fall into 3 major groups: short duration, intermediate duration, and long duration. You can see those in table 46.6. The short duration insulins can be subdivided into 2 groups: rapid acting and slower acting. Time courses for different insulin types are shown again in figure 46.2. Selected properties of insulin types are shown in table 46.7. So here are some excellent spots to hit pause so you can review the different types of insulin, the time course of action after a subcutaneous injection. And then this next table here shows the properties of insulin types. Again, hit pause. So, speaking on short duration or rapid acting, short duration insulins are administered in association with meals to control the postprandial rise in blood glucose. To provide glycemic control between meals and at night, short-acting insulins must be used in conjunction with an intermediate or long-acting agent in people with type 1 diabetes. All 3 of the rapid-acting insulins are formulated as clear solutions, and all 3 require a prescription. For routine therapy, all 3 are given by the subcutaneous route. So we'll start with insulin Lispro, also known as Humalog, which is a rapid-acting analog of regular insulin. Effects begin within 15 to 30 minutes of sub-Q injection and persist for 3 to 6 hours. Insulin Lispro acts faster than regular insulin, but has a shorter duration of action. Because of its rapid onset, insulin Lispro can be administered immediately before eating, or even after eating. In contrast, regular insulin is generally administered 30 to 60 minutes before meals. The usual route for insulin Lispro is sub-Q by injection or use of an insulin pump. Insulin Lispro is commercially available in 10 ml vials and as 3 ml pre-filled pens. The structure of insulin Lispro is nearly identical to that of natural insulin. The only difference is that the positions of 2 amino acids have been switched. Because of this switch, molecules of insulin Lispro aggregate less than do molecules of regular insulin. which explains why the insulin Lispro acts more rapidly. That brings us to the next one. Insulin aspart, also known as Novolog, is an analog of human insulin with a rapid onset, 10 to 20 minutes, and short duration, 3 to 5 hours. Insulin aspart is very similar to insulin Lispro. Again, insulin aspart is supplied in a 10 ml vial or a 3 ml pre-filled pen. Dosing is almost always done by a sub-Q injection or a sub-Q infusion. Because insulin acts rapidly, injection should be made 5 to 10 minutes prior to a meal. And the last one, insulin glulisine. Like insulin Lispro and insulin aspart, insulin glulisine, or Apidra, is a synthetic analog of natural human insulin with a rapid onset, again 10 to 15 minutes, and short duration, again 3 to 5 hours. Owing to its rapid onset, the drug should be administered close to the time of eating. Administration is always done by sub-Q injection or a subcutaneous sub-Q infusion. Insulin glulisine is available as a 10 ml vial or a 3 ml pre-filled insulin pen. So that takes us to the short duration or slower acting insulins. That is our regular insulin, also known as Humulin R or Novolin R, which are unmodified human insulin. The product has 4 approved routes: subcutaneous, sub-Q infusions, an IM injection, though rare, and oral inhalation. For routine treatment of diabetes, regular insulin can be injected before meals to control postprandial hyperglycemia and infused subcutaneously to provide a basal glycemic control. After sub-Q injection, molecules of regular insulin form small aggregates at the injection site. As a result, absorption is slightly delayed. Its effects begin 30 to 60 minutes and peak in 1 to 5 hours and last up to 10 hours. Onset is slower than with the rapid-acting insulins and faster than with the longer-acting insulins. Because of this delay, most people using insulin pumps use a rapid-acting insulin analog instead of regular insulin. Regular insulin is supplied as a clear solution. 2 concentrations are available, 100 units or 500 units per ml. Regular insulin is the only type available in a 500 units per ml. The U100 preparations are used by most patients. The U500 concentration is reserved for patients with extreme insulin resistance. Care should also be taken when using a U500 insulin because insulin syringes are calibrated to be used for U100 products. Extra caution and education are critical when working with patients that use U500 insulin. Except for the U500 formulations, all formulations of regular insulin are available without a prescription. Which brings us now to the intermediate duration. The neutral protamine Hagedorn or NPH insulin suspension, NPH insulin or Humulin, or also known as Novolin, also known as the isophane insulin, is prepared by the conjugating regular insulin with protamine, which is a large protein. The presence of protamine decreases the solubility of NPH insulin and therefore delays absorption. As a result, onset of action is delayed and the duration of action is extended. Because onset is delayed, NPH insulin cannot be administered at mealtimes to control postprandial hyperglycemia. Rather, the drug is injected twice or 3 times daily to provide glycemic control between meals and during the night. Of the longer-acting insulins in current use, NPH insulin is the only one suitable for mixing with a short-term or short-acting insulin. Because protamine is a foreign protein, allergic reactions are possible. NPH insulins are supplied as cloudy suspensions that must be agitated before administration. Administration is by subcutaneous injection only, and like regular insulin, NPH insulins are available without prescription. NPH insulin is available in 10 ml vials and 3 ml pre-filled insulin pens. And that takes us to the long duration. Insulin glargine, also known as Lantus, is a modified human insulin with a prolonged duration of action that can last up to 24 hours. The drug is indicated for a once-daily subcutaneous dosing to treat adults with and children with type 1 diabetes and adults with type 2 diabetes. That being said, some patients require twice-daily administration to achieve a full 24 hours of basal coverage. Dosing may be done any time of the day, morning, afternoon, or evening, but should be done at the same time every day if possible. Insulin glargine differs from natural human insulin by 4 amino acids. Therefore, when injected subcutaneously, it forms microprecipitates that slowly dissolve and thereby release insulin glargine in small amounts over an extended time. In contrast to other long-acting insulins, such as Detamir, which cause blood levels to rise to a peak and then fall to a trough, insulin glargine achieves blood levels that are relatively steady. Insulin glargine is supplied as a clear solution in 10 ml vials containing 100 units per ml, and as a pre-filled solo star pen. The drug should not be mixed with any other insulin. Which brings us to the other long-acting. Insulin Detamir, also known as Levemir, is a human insulin analog with a slow onset and dose-dependent duration of action. At low doses of 0.2 units per kilogram, effects persist about 12 hours. At higher dosages, such as 0.4 units per kilogram, effects persist for up to 20 to 24 hours. Because of its slow onset and prolonged duration, insulin Detamir is used to provide a basal glycemic control. It is not given before meals to control postprandial hyperglycemia. Compared with NPH insulin, insulin Detamir has a slower onset and a longer duration. Insulin Detamir is supplied as a clear colorless solution, again 100 units per ml, in 10 ml vials or a 3 ml flex pen. Dosing is done once or twice daily by subcutaneous injection. Insulin Detamir should not be mixed with any other insulin and must not be given intravenously. The drug is also only available by a prescription. Which leads us to the last one, our ultra-long duration. Insulin Degludec, also known as Tresiba, is the only human insulin analog with an ultra-long duration of action. Effects of insulin Degludec persists for up to 42 hours. Because of its prolonged duration, insulin Degludec is used to provide basal glycemic control. Similar to insulin glargine, insulin Degludec does not have a peak. This insulin Degludec is supplied as a clear, colorless solution in 2 concentrations of a Flex Touch pen, either the 100 units per ml or 200 units per ml. Dosing is done once daily by a subcutaneous injection. It should not be mixed with any other insulins and must not be given intravenously. The drug is available, again, by prescription only. So, concentrations. In the US, insulin is available in 2 concentrations, again, that 100 units or 500 units per ml. Preparations containing 40 units ml are available in other countries, but again, not in the United States. And it can be employed for routine replacement therapy. All insulin types are available in U100 formulations. Only one product, the Humulin R brand of regular insulin, is formulated in the U500 strength. This product, which is available from the manufacturer by special request, is reserved for emergencies and for patients again with severe insulin resistance, generally defined as needing more than 200 units per day. So, patient education, especially on mixing insulins. Mixing should be done only with insulins of proven compatibility. Of the three longer-acting insulins in current use, only NPH is appropriate for mixing with a short-acting. When a mixture is prepared, the short-acting insulin should be drawn into the syringe first to avoid contaminating the stock vial of the short-acting insulin with NPH. Commercially available premixed combinations do exist and are here on this following table. It's a good spot to hit pause if you're unfamiliar with the different types, but there are some available. Other patient education. Injection sites. The most common sites of sub-Q injections are the upper arm, the thigh, and the abdomen. Because the rates of absorption vary among sites, patients should make all injections into the same general area. To reduce the risk of lipodystrophy, injection within the chosen area should be made in different spots, preferably 1 inch apart ideally. Each spot should be used only once a month. Subcutaneous infusions, the portable insulin pumps. These computerized devices deliver a basal insulin infusion plus boluses or bolus doses each day before each meal. In other words, the pump uses only one type of insulin for both the basal and mealtime coverage. The basal infusion is usually about 1 unit per hour and can be programmed to match the patient's metabolic requirement. Basal rates can even be adjusted to different rates throughout the day, depending on the individual needs of the patient, and are adjustable in some pumps up to 1/100 of units per hour. Mealtime boluses are calculated to match carbohydrate intake and can be adjusted to within 1/10 of a unit. The pumps are about the size of a small cell phone, weigh about 4 ounces, and are worn on a belt or in a pocket. An infusion set delivers insulin from the pump to the subcutaneous catheter, usually located on the abdomen. The infusion set should be replaced every 1 to 3 days, at which time the catheter is removed to a new infusion site. Because the pump delivers short-acting insulin, insulin levels will drop quickly if the pump is removed. Accordingly, the pump should remain in place most of the day. However, it can be removed for 1 to 2 hours on special occasions. External insulin pumps cost anywhere between $3,000 to $5,000. Infusion sets, insulin, glucose monitoring materials add another $300 or more per month to the bill. Aside from expense, the main drawback of pumps is delivery of too little insulin owing to the formation of insulin microdeposits within the tubing. Bringing us to implantable insulin pumps. These devices are surgically implanted in the stomach or abdomen and deliver insulin either intraperitoneally or intravenously. Like external pumps, internal pumps deliver a basal insulin infusion plus bolus doses with meals. Insulin delivery is adjusted by external telemetry. Compared with multiple daily injections, pumps produce superior glycemic control, cause less hypoglycemia and weight gain, and can improve the quality of life. As with external pumps, delivery of insulin can be impeded by the formation of insulin microprecipitates. Implantable pumps are experimental and not yet available for the general use. Inhalation. Inhalation of insulin is an attractive alternative to needle-based dosing. In clinical trials, patient satisfaction with inhaled insulin has been much higher than with insulin injection. One delivery system is currently available for insulin inhalation, Afrezza. This inhaled mealtime insulin product provides good glycemic control with a relatively low incidence of hypoglycemia, and has demonstrated little or no effect on pulmonary function in studies to date. Even though it has not demonstrated effects on pulmonary function, Afrezza is known to cause bronchospasms in patients with chronic lung disease. Therefore, there is a risk evaluation and mitigation strategy program in place to protect patients with chronic obstructive pulmonary disease or asthma. Before prescribing Afrezza, the provider should obtain a detailed medical history, physical exam, and spirometry. Storage of insulin. Insulin in unopened vials should be stored under refrigeration until needed. Vials should not be frozen. When stored unopened under refrigeration, insulin can be used up to the expiration date on the vial. Vials in current use can be kept at room temperature for up to 1 month without significant loss of activity. However, direct sunlight and extreme heat must be avoided. Partially filled vials should be discarded after several weeks if left unused. Injecting insulin stored at room temperature causes less pain than injecting cold insulin, and it reduces the risk for lipodystrophy. Mixtures of insulin prepared in vials are stable for 1 month at room temperature and for 3 months under refrigeration. Mixtures of insulin in prefilled syringes, whether they're plastic or glass, should be stored in a refrigerator, where they will be stable for at least 1 week and perhaps 2 weeks. The syringe should be stored vertically, with the needle pointing up to avoid clogging the needle. Before the administration, syringes should be agitated gently to resuspend the insulin. This is one of the few sections where you can tell the book is slowly out of date because insulin pens no longer come with a single syringe. We can just simply swap out the needles, so that's not 100% accurate for 2025. Its therapeutic use, however. Indications. The principal indication for insulin is diabetes mellitus. Insulin is required by all patients with type 1 diabetes and by many patients with type 2 diabetes. In fact, most of the insulin sold is used by people with type 2 diabetes, largely because type 2 diabetes accounts for 90 to 95% of all diabetes cases. Insulin therapy for diabetes. Insulin is given to all patients who have type 1 diabetes and to many who have type 2. In addition, insulin is the preferred drug to manage gestational diabetes. In treating these disorders, the objective is to prevent complications by keeping blood glucose within an acceptable range. When therapy is successful, both hyperglycemia and hypoglycemia are minimized, and the long-term complications of diabetes are avoided. Dosage. To achieve optimal glucose control, insulin dosage must be closely matched with insulin needs. If carbohydrate intake is increased, insulin dosage must be increased too. When a meal is missed or is low in carbohydrates, or when physical activity levels increase, the dosage of insulin must be decreased. Dosing requirements, additional adjustments to meet specialized needs. For example, insulin needs are increased by infection, stress, obesity, the adolescent growth spurt, and pregnancy after the first trimester. Conversely, insulin needs are decreased by exercise and during the first trimester of pregnancy. To ensure that insulin dosage is coordinated with insulin requirement, the patient and the healthcare team must work together to establish an integrated program of nutrition, exercise, insulin replacement therapy, and appropriate blood glucose monitoring. Total daily dosages may range from 0.1 units per kilogram body weight to more than 2.5 units per kilogram. For patients with type 1 diabetes, the initial dosage range from 0.5 to 0.6 units per kilo per day. For patients with type 2 diabetes, initial dosage typically ranges from 0.2 to 0.6 units per kilo per day. The dosing schedule. The schedule of insulin administration helps determine the extent to which glucose control can be achieved. 3 dosing schedules are compared here. These examples or example regimens include the use of a twice-daily premixed insulin regimen, intensive basal and bolus strategy, and continuous subcutaneous insulin infusions. Although 3 example regimens are discussed, it should be noted that practitioners can use available insulin products in a number of ways and combinations to meet the patient-specific needs and their treatment goal. So if you're using a twice-daily premixed regimen, there are several premixed insulin products on the market. As shown in figure 46.4a, a twice-daily regimen of such a premixed insulin product can be used to provide both the basal and the prandial insulin coverage. The advantage of this strategy is that patients only have to give 2 injections per day. A disadvantage, however, is that if given with breakfast and dinner, there is no mealtime coverage at lunch. Additionally, using a fixed combination does not allow for adjustments of the long-acting or short-acting insulin individually. If the dose is changed, both components are technically altered at this point. Intensive basal bolus strategy. So for patients with type 1 diabetes, an intensive basal bolus strategy is often used. As shown in figure 46.4b, the strategy involves the use of long-acting insulin, such as Lantus, in addition to a short-acting insulin, such as regular insulin. This insulin dosing strategy allows for very good basal coverage and the ability to dose a short-acting insulin with each meal, and is needed to cover snacks or elevated blood glucose levels. Continuous subcutaneous insulin infusion. So the CSII is accomplished using a portable infusion pump connected to indwelling subcutaneous catheters. 4 types of insulin may be used: irregular, Lispro, Aspart, and glulisine. To provide a basal level of insulin, the pump is set to infuse insulin continuously at a slow but steady rate. To accommodate insulin needs created by eating, the pump is triggered manually to provide a bolus dose, matched in size to the carbohydrate content of each meal. Therefore, CSII can adapt to altered insulin needs. Although the use of CSII allows for ease of administration, the use of frequent SMBG is essential to achieve optimal glycemic control. Infusion pumps were discussed earlier in this section on subcutaneous infusion. Achieving optimal glucose control. As we have seen, the primary requirement for achieving tight glucose control is a method of insulin delivery that permits dosage adjustments that accommodate ongoing variations in insulin needs. Intensive basal, bolus therapy, and CSII meet this criterion. In addition to an adaptable method of insulin delivery, achieving tight glucose control requires the following. The first being careful attention to all elements of the treatment program: your diet, exercise, insulin replacement therapy. It also requires a defined glycemic target. It requires self-monitoring of blood glucose in concordance with the patient's individualized management plan. It requires a degree of patient motivation, extensive patient education. Tight glucose control cannot be achieved without the informed participant of the patient. Accordingly, patients must receive thorough instruction on the following: the nature of diabetes, the importance of optimal glucose control, the major components of treatment routine, whether it's insulin replacement, SMBG, diet, or exercise, procedures for purchasing insulin, syringes, and needles, The importance of avoiding arbitrary changes between insulins from different manufacturers. Methods of insulin storage. Procedures for mixing insulins if applicable. Calculations of dosage adjustments. Techniques of insulin administration. And lastly, the methods for monitoring their own blood glucose. In the final analysis, responsibility for managing diabetes rests with the patient. The healthcare team can design a treatment plan and provide education and guidance. However, optimal glucose control can only be achieved if the patient is actively involved in their own care. So, complications of insulin treatment. The common one, or the most common sense one, would be hypoglycemia. Hypoglycemia, which is when a blood glucose level drops below 70, occurs when the insulin levels exceed insulin need. A major cause of insulin excess is overdose. Imbalance between the insulin levels and insulin needs can also result from reduced intake of food, vomiting, and diarrhea, which reduce absorption of nutrients. Excessive consumption of alcohol, which promotes hypoglycemia, and unusual intense exercise, which again promotes that cellular glucose uptake and metabolism. Lastly, childbirth, which reduces insulin requirements. So patient education that we would give on hypoglycemia. A patient with diabetes and their families should be familiar with the signs and symptoms of hypoglycemia. Establishing whether patients are experiencing hypoglycemia and whether they recognize hypoglycemic symptoms is recommended as a critical component of an encounter with a patient with diabetes. Some symptoms result from the activation of the sympathetic nervous system. Others arise from a lack of glucose within the CNS. When glucose levels fall rapidly, activation of the sympathetic nervous system occurs, resulting in tachycardia, palpitations, sweating, and nervousness. However, if glucose declines gradually, symptoms may be limited to those of CNS origin. Mild CNS symptoms include headache, confusion, drowsiness, and fatigue. If hypoglycemia is severe, convulsions, coma, and death can occur. So, the rapid treatment of hypoglycemia is mandatory. If hypoglycemia is allowed to persist, irreversible brain damage and death may result. In conscious patients, glucose levels can be restored with a fast-acting oral sugar. So glucose tablets, orange juice, sugar cubes, honey, corn syrup, and non-diet soda. However, if the swallowing reflex or the gag reflex is suppressed, nothing should be administered by mouth. In cases of severe hypoglycemia, IV glucose is the preferred treatment. Parenteral glucagon is an alternative treatment. In anticipation of a hypoglycemic episode, people with diabetes should always have an oral carb available. Sugared candy, sugar cubes, glucose tablets. Some prescribers recommend that patients keep glucagon on hand too, particularly people who are on insulin therapy. Patients should carry some form of identification, a medical alert bracelet, to inform emergency personnel of their condition. In some patients, hypoglycemia occurs without producing the symptoms noted previously. This is known as a hypoglycemic unawareness. As a result, the patient remains unaware of hypoglycemia until the blood sugar has become dangerously low. Hypoglycemia unawareness is a particular problem among patients practicing tight glucose control. This is because the patient experiences more frequent hypoglycemia. They start to have diminished symptoms over time. The risk for dangerous hypoglycemia can be minimized by frequently monitoring blood glucose. Additionally, current recommendations state that treatment goals should be temporarily loosened, such as for several weeks, for people experiencing hypoglycemia, unawareness so that they can regain hypoglycemia awareness. Hypoglycemia can result in coma. The most definitive diagnosis is made by measuring plasma glucose levels. In hypoglycemic coma, glucose levels are very low. Other complications. Hypokalemia. Insulin promotes the uptake of potassium by cells. Insulin activates a membrane-bound enzyme, your sodium-potassium ATPase, that pumps potassium into cells and pumps sodium out. Therefore, in addition to lowering blood glucose levels, insulin can lower blood levels of potassium. When insulin dosage is proper, effects on potassium are unremarkable. However, if insulin dosage is excessive, clinically significant hypokalemia can result. Effects on the heart are the greatest concern. Hypokalemia can reduce contractility and cause potentially fatal dysrhythmias. Lipohypertrophy. Lipohypertrophy is the accumulation of subcutaneous fat, which can occur when insulin is injected too frequently at the same time. Fat accumulates because insulin stimulates fat synthesis. When use of the site is discontinued, excess fat is eventually lost. Your lipohypertrophy can be minimized through systematic rotation of the injection site. Allergic reactions. Rarely, patients experience systemic allergic responses. These reactions develop rapidly and are characterized by the widespread appearance of red and intense, itchy welts. Breathing difficulty may develop. If severe allergy develops in a patient who nonetheless must continue insulin use, a desensitization procedure can be performed. This process entails giving small initial doses of human insulin, followed by a series of progressively larger doses. Drug interaction. Your hypoglycemic agents. Drugs that lower blood glucose levels can intensify hypoglycemia induced by insulin. Among these drugs are your sulfonylureas, your glycides, and alcohol. When these drugs are combined with insulin, special care must be taken to ensure the best as possible that blood glucose does not fall too low. Your hyperglycemic agents, drugs that raise your blood glucose, such as your thiazide diuretics, your glucocorticoids, and your sympathomimetics, can counteract the desired effects of insulin. When these agents are combined with insulin dosages may need to be increased. Your beta-adrenergic blocking agents. Beta blockers can delay awareness of and response to hypoglycemia by masking signs that are associated with stimulation of the sympathetic nervous system, your tachycardias and palpitations, that hypoglycemia normally causes. Furthermore, beta blockers impair glycogenolysis, and because glycogenolysis is one means by which the body can respond to and counteract a fall in blood glucose, beta blockers can make insulin-induced hypoglycemia even worse by preventing the body's natural counter-regulatory response. Which brings us to the non-insulin medications for the treatment of diabetes. The non-insulin medications for the treatment of diabetes fall into two major groups: oral drugs and non-insulin injectable drugs. Their actions and major adverse effects are shown here on this table. So here is an excellent spot to hit pause so you can read through some of the many different types of anti-diabetic medications. Oral drugs. There are 7 main families of oral drugs. Antidiabetic drugs, your biguanides, sulfonylureas, meglitinides, thiazolidinedides, alpha-glucosidase inhibitors, and DDP4 inhibitors, your SGLT2 inhibitors. These agents are all approved for the use of type 2 diabetes, but agents such as your SGLT2 inhibitors are used off-label in combination with insulin for the treatment of type 1 diabetes, with clinical studies in progress still. In the past, oral agents were used only after a program of diet modification and exercise had failed to yield sufficient glycemic control. Today, one oral agent, metformin, is usually started immediately after type 2 diabetes has been diagnosed. The oral agents work in a variety of ways. Some of them, notably the sulfonylureases and glycosides, actively drive blood glucose down by increasing insulin release from the beta cells of the pancreas. Others, notably metformin, the alpha-GLucosidase inhibitors and SGLT2 inhibitors, don't drive blood glucose down. Rather, they simply modulate the rise in glucose that happens after a meal. This distinction is not just academic. If taken when blood glucose is normal or low, agents that drive glucose down would cause hypoglycemia. Hypoglycemia is not a large risk with the drugs that simply impair the postprandial rise in blood glucose. So let's start with metformin, also known as glucophage, classified chemically as a biguanide, is the drug of choice for initial therapy in most patients with type 2 diabetes. Typically, metformin is started immediately after the diagnosis. The most common side effect are gastrointestinal disturbances, such as lactic acidosis and a potentially fatal complication, which is rare. Its mechanism of action, therefore. Metformin lowers blood glucose and improves glucose tolerance in three ways. First, it inhibits glucose production in the liver. Second, it reduces glucose absorption in the gut. And lastly, it sensitizes insulin receptors in target tissues, and thereby increases glucose uptake in response to whatever insulin may be available. In contrast to sulfonylurease, metformin does not stimulate insulin release from the pancreas. As a result, metformin does not actively drive blood glucose levels down, and therefore poses little, if any, risk for hypoglycemia when used alone. Its pharmacokinetics. After oral dosing, metformin is slowly absorbed in the small intestine. Of particular interest, metformin is not metabolized. Rather, it is excreted unchanged by the kidneys. Therefore, in the event of renal impairment, metformin can accumulate to a toxic level. Its therapeutic use, therefore, in glycemic control, metformin is used to lower blood sugar in patients in type 2 diabetes. In the past, treatment was reserved for patients who had not responded adequately to a program of diet modification and exercise. Today, however, treatment is usually begun as soon as it is diagnosed as a type 2 diabetes. Metformin may be used alone or in combination with other agents. When used alone, metformin lowers fasting and postprandial blood glucose levels. When metformin is used as a component of a combination therapy, the combination lowers blood sugars more effectively than either drug alone, which is to be expected because other available agents act through different mechanisms. Metformin is well suited for patients who tend to skip meals. When meals are skipped, your blood sugar can drop below a level that is healthy. But because metformin does not lower blood glucose any further, it won't make any situation any worse. In contrast, drugs that actively lower blood glucose, such as your sulfonylurease, can drop a normal or slightly low blood glucose to a clinically significant hypoglycemia. So for the prevention of type 2 diabetes, data from the Diabetes Prevention Program, or DDP, a large study sponsored by the National Institute of Health indicates that metformin can delay development of type 2 diabetes in high-risk individuals. The DDP enrolled 3,234 people aged between 25 to 85. All participants had impaired glucose tolerance, and all were severely overweight. Participants were randomly assigned to one of the three protocols. Again, the intensively lifestyle changes with the aim of reducing body weight by 7% through moderate exercise, combined with a low-fat diet. Then the second, the treatment with metformin, and the third, the treatment with a placebo. The result, metformin reduced the risk for developing type 2 diabetes by 31%. However, benefits were limited primarily to younger patients and to those who were most overweight. The drug was relatively ineffective in older patients and those less overweight. It must be stressed, however, that metformin is not a substitute for diet and exercise. In fact, the DDP showed that lifestyle changes are even more effective than metformin. The combination of moderate exercise plus weight loss reduced the average risk for type 2 diabetes by 58%. Benefits were greatest, 71% for people older than 60 years. Gestational diabetes. For decades, insulin was considered the preferred, if not the only, anti-diabetic drug for the managing diabetes during pregnancy, whether the mother had type 1 or type 2 diabetes. Recent clinical studies have compared metformin with insulin in pregnant women with type 2 diabetes. Multiple outcomes were assessed, including the glycemic control in the mother and blood glucose, and APGAR scores of the neonate. The result, outcomes with metformin were essentially the same as those with insulin, the traditional agent for managing gestational diabetes, suggesting that metformin may become an acceptable alternative for many women. Do note, though, that the data obtained with metformin do not apply to other classes of oral agents. So, for your polycystic ovary syndrome, or PCOS, PCOS is a combined endocrine metabolic disorder characterized by androgen excess and insulin resistance. It affects about 5 to 10% of women of reproductive age. Symptoms include irregular periods, anovulation, infertility, acne, and hirsutism. Although not approved for PCOS, metformin can be very helpful. Metformin treatment increases insulin sensitivity and decreases insulin levels, which, through an indirect mechanism, lowers androgen levels. The net result is improved glucose tolerance, improved ovulation, and increased pregnancy rates. Its side effects, therefore. The most common side effects are decreased appetite, nausea, and diarrhea. These generally subside over time. However, 3 to 5% of patients, GI side effects lead to discontinuation of treatment. Therefore, the dose of metformin must be titrated up to the target dose to minimize the severity of GI side effects. Metformin decreases absorption of vitamin B12 and folic acid and can thereby cause deficiencies of both. Deficiency of B12, in turn, can contribute to peripheral neuropathy, a common long-term consequence of diabetes. However, there is no proof yet that metformin actually makes diabetic neuropathy worse. Likewise, there is no current recommendation about prescribing vitamin B12 for patients who are taking the drug. As was discussed in Chapter 65, deficiency of folic acid during pregnancy can impair development of the central nervous system, resulting in neural tube defects, which manifest as an encephalopathy or spinal bifida. Nonetheless, metformin appears to be a safe drug for use during pregnancy. In contrast, metformin does not cause weight gain. In fact, patients maintain or possibly lose weight while on metformin. As a result, metformin is considered a weight-neutral antidiabetic drug, in contrast to several other antidiabetic drugs that tend to increase weight. Appetite suppression and weight loss in response to metformin can occur both in the presence and absence of nausea, indicating that reduced food intake because of metformin-induced nausea is not the only reason for weight loss in the patients who do lose weight. There is, however, a black box warning to metformin. Severe metabolic acidosis can occur with the accumulation of metformin. The highest risk occurs in diabetic patients with significant renal impairment. Metformin and other bioguanides inhibit mitochondrial oxidation of lactic acid and can thereby cause lactic acidosis. This condition is a medical emergency and has a mortality rate of about 50%. Fortunately, lactic acidosis is rare, only 3 cases per 100,000 patients. When metformin is used at recommended doses in patients with good renal function, However, in patients with renal insufficiency, metformin can rapidly accumulate to toxic levels. Accordingly, the drug must never be used by these people. In addition, metformin must be avoided in patients who are prone to increased lactic acid production. Among these are patients with liver disease, severe infection, or a history of lactic acidosis, patients who consume alcohol to excess, and patients with shock and other conditions that can also result in hypoxemia. All patients taking metformin should be informed about the early signs of lactic acidosis, your hyperventilation, myalgia, malaise, and unusual somnolence, and instructed to report these to the prescriber. Metformin should be withdrawn until lactic acidosis has been ruled out. If lactic acidosis is diagnosed, hemodialysis can correct the condition and remove accumulated metformin. Because heart failure can predispose to lactic acidosis, metformin is contraindicated for people with failing hearts. However, in one study, patients with heart failure who took the drug were less likely to die than those who took a sulfonylurea. These data suggest that the use of metformin in heart failure is much safer than the previously believed. It does have, however, drug interactions. Alcohol. Like metformin, alcohol can inhibit breakdown of lactic acid and can thereby intensify lactic acidosis caused by metformin. To minimize this risk, patients should avoid consuming alcohol in excess, whether acutely or long term. Discontinuing alcohol entirely would be even safer. Urosimetidine, or Tagamet, a histamine 2 H2 blocker used to reduce gastric acidity, can increase the risk for lactic acidosis. Accordingly, if an H2 blocker is indicated, another member of the family should be used because cimetidine is the only H2 blocker that poses this risk. Iodinated radiocontrast media. IV radiocontrast media that contains iodine poses a risk for acute renal failure, which could exacerbate metformin-induced lactic acidosis. To reduce this risk, patients should discontinue metformin 1 to 2 days prior to any kind of elective radiography. Metformin can then be resumed 48 hours after the procedure, provided lab tests show the renal function is normal. Its preparation and dosage, as well as its administration. Metformin is available alone in immediate release tablets as glucophage and in extended release tablets as glucophage XR. The dosage is 500, 850, and 1000 milligrams in immediate release. As in extended release, that's 500, 750, and 1000 milligrams. There is also a oral solution known as Riomet, which has 500 milligrams per 5 ml. In addition, the drug is available in several fixed doses in combinations with other drugs for type 2 diabetes. With the IR tablets and oral solution, the recommended initial dose is 500 milligrams twice daily or 850 once daily, taken with a meal. The usual maintenance dose is 850 milligrams twice daily. The maximal dose is 850 milligrams 3 times a day for adults or 2000 milligrams per day for children 10 to 16. With the extended release tablets, dosing is done once daily with the evening meal because this timing may enhance absorption owing to the slower GI transit time at night. For previously untreated patients, the initial dose is 500 milligrams per day. For patients already taking metformin, the total daily dosage remains the same. It's simply taken all at once. The maximal daily dosage, again, is 2000 milligrams. Which brings us to sulfonylureas, which was introduced back in the 1950s. Were the first oral antidiabetic drugs available. They work by promoting insulin release, and hence they are only to be used in type 2 diabetics. This drug were a major advance in diabetes therapy. For the first time, some patients could be treated with an oral medication, rather than with daily injections of insulin. The major side effect with these drugs were hypoglycemia, however, and weight gain. The sulfonylureas fall into two groups, first-generation and second-generation agents. Both generations, however, reduce glucose levels to the same extent. So how do they differ? Second-generation agents are much more potent than the first generation, and therefore the doses are much lower. More important, with the second-generation agents, significant drug-to-drug interactions are less common and have outcomes that tend to be milder. Because of these differences, the second-generation agents have nearly completely replaced the first-generation agent in clinical practice. Accordingly, our discussion in this chapter is limited to second-generation agents. 3 second-generation agents are currently available. All have similar actions and side effects and all share the same application. So you'll see these here on the following table. A good spot to hit pause. So, what are the mechanisms of action? Well, your sulfonylureas act primarily by stimulating the release of insulin from pancreatic islets. If the pancreas is incapable of insulin synthesis, sulfonylureas will be ineffective, which is why they don't work in patients with type 1 diabetes. With prolonged use, sulfonylureas may increase target cell insensitivity to insulin. It therefore promotes insulin release by binding with and thereby blocking adenosine triphosphate sensitive potassium channels in the cell membrane. As a result, the membrane depolarizes, thereby permitting influx of calcium, which in turn causes insulin release. The extent of the release is glucose dependent and diminishes when the plasma glucose declines. Its therapeutic use. Sulfonylureas are indicated only for type 2 diabetes. These drugs are of no help with patients, again, with type 1 diabetes. Like all other drugs for type 2 diabetes, the sulfonylureas should be used in conjunction with lifestyle program inclusion of dietary and physical activity interventions. It may also be used alone or together with other anti-diabetic drugs. It does come again with adverse effects though. Hypoglycemia. Sulfonylureas cause a dose-dependent reduction in blood glucose and thereby can cause hypoglycemia. Importantly, regardless of what the glucose level is, high, normal, or low, this medication will make it go lower. If the level is high, reducing it will be therapeutic. However, if the level is normal, reducing it will cause mild hypoglycemia. And if the level is already low, reducing it will cause severe hypoglycemia. Although sulfonylurea-induced hypoglycemia is usually mild, severe and even fatal cases have occurred. Hypoglycemia is sometimes persistent, requiring infusion of dextrose for several days. Hypoglycemic reactions are more likely in patients with kidney or liver dysfunction because they are eliminated by the hepatic metabolism and renal excretion, and therefore may accumulate to dangerous levels when liver or kidney function is impaired. If signs of hypoglycemia develop, fatigue, excessive hunger, profuse sweating, or palpitations, the patient should treat the hypoglycemia and notify their prescriber. Cardiovascular toxicity. There has been controversy regarding the possibility of adverse cardiovascular reaction to oral anti-diabetic drugs. In the 1970s, the large multi-center university group Diabetes Program, or UGDP, published results indicating that tolbutamide was linked to an increased risk for mortality with sudden cardiac death. In the UGDP study, cardiac mortality was 2.5 times greater among subjects treated with a combination of diet therapy and tolbutamide than among control subjects who received diet therapy alone. The UGDP study has been criticized on several grounds, including design, patient selection, dosing, and compliance. Subsequent clinical trials, including the UK-PDS, failed to confirm the conclusions of the UGDP report. The ADA, which initially endorsed the UGDP study, has since withdrawn its support. Nonetheless, the risk for sudden cardiac death remains a concern, albeit a small one, and therefore appropriate caution should be exercised. Its use in pregnancy and lactation. Sulfonylureas should be avoided during pregnancy. Although adequate studies in humans are lacking, the medication are teratogenic in animals. Therefore, because sulfonylurea therapy during pregnancy often fails to provide good glycemic control, and because even mild hyperglycemia may be hazardous to the fetus, insulin is generally preferred for managing the diabetic pregnancy. It is especially important to avoid sulfonylureas near term. Newborns exposed to these agents at the time of delivery have experienced severe hypoglycemia lasting 4 to 10 days. Therefore, if sulfonylurea has been taken during pregnancy, it should be discontinued at least 48 hours before the anticipated time of delivery. Again, it should not be taken by women who are nursing either. These drugs are excreted into breast milk, posing a risk for hypoglycemia in the infant. If the woman wishes to breastfeed, she should substitute for insulin. Drug interactions. Alcohol. When alcohol is combined with sulfonylurea, a disulfiram-like reaction may occur. This syndrome includes flushing, palpitations, and nausea. Disulfiram reactions are discussed in Chapter 31. Also, alcohol can potentiate the hypoglycemic effects of sulfonylureas. Accordingly, patients using the drug must be warned about the risk of alcohol consumption in combination with the medication. Drugs that can intensify hypoglycemia. A variety of drugs acting by diverse mechanisms can intensify hypoglycemic responses to most sulfonylureas, including nonsteroidal anti-inflammatory drugs, sulfonamide antibiotics, alcohol, and cimetidine. Caution must be exercised when sulfonylurea is used in combination with these drugs. Your beta-adrenergic blocking agents, your beta blockers, can diminish the benefits of sulfonylureas by suppressing insulin release. In addition, because beta blockers can mask sympathetic responses to declined blood glucose, the use of beta blockers can delay awareness of hypoglycemia. Your preparation, dose, and administration was shown in Table 4610, so it's a good spot to reference. Your megalotonides, your glinides, I'm going to call them glinides, are antidiabetic agents that have the same mechanism as your sulfonylureas, the stimulation of pancreatic insulin release. The main difference, however, between the glinides and the sulfonylureas is their pharmacokinetic profile. The glinides are shorter acting and are taken with each meal. Only 2 glinides are currently available, your repaglinide and netaglinide. So, repaglinide, its action and use. Like your sulfonylureas, repaglinide or Prandin blocks ATP-sensitive potassium channels on pancreatic beta cells and thereby facilitates calcium influx, which leads to increased insulin release. In clinical trials, repaglinide was about as effective as glyburide or glipizide. The drug is approved for type 2 diabetes only. Because repaglinide has the same mechanism as sulfonylureas, patients who do not respond to sulfonylureas will not respond to this agent either. Repaglinide is approved for monotherapy or combined therapy with metformin or glitazone. Its pharmacokinetics. Repaglinide undergoes rapid absorption followed by rapid elimination. Blood levels peak within 1 hour of oral dosing and return back to baseline about 4 hours later. Elimination results from hepatic metabolism followed by biliary excretion. The drug's half-life is only 1 hour. Blood levels of insulin rise and fall in parallel with levels of repaglinide. And because levels of repaglinide rise and fall quickly, so do blood levels of insulin. It does have adverse effects, which are generally well tolerated. The main significant adverse effect is hypoglycemia. In patients with liver dysfunction, metabolism of repaglinide may be slowed, and hence the risk for hypoglycemia may be increased. Because of possible hypoglycemia, it is imperative that patients eat no later than 30 minutes after taking the drug. Your drug interactions. Your gemfibrozole, or Lopid, a drug used to lower triglyceride levels, can inhibit the metabolism of repaglinide, thereby causing its levels to rise. Hypoglycemia can result. If possible, the combination should be avoided. Your fenofibrate can be used instead of the gemfibrozole. Its preparation, dosage, and administration, therefore. Repaglinide is available in 0.5, 1, and 2 milligram tablets. Administration must always be associated with a meal. For patients who have not used another oral antidiabetic drug, the initial dose is 0.5 milligrams, taken for 0 to 30 minutes before each meal. Patients who have used other oral antidiabetic drugs may start at a 1 or 2 milligram before each meal. The maximal dose is 16 milligrams, or 4 milligrams with each meal for up to 4 meals. Bringing us to netiglinide, basic pharmacology and therapeutic use. The pharmacology of netiglinide, or Starlix, is nearly identical to that of repaglinide. Both drugs have the same indication, the treatment of type 2 diabetes, either as monotherapy or combined with metformin or glitazone. They also have the same mechanism of action and major adverse effects, and perhaps the same major drug interaction. The two drugs differ primarily with respect to time course. Specifically, netiglinide has a slightly faster onset, 30 minutes versus the 1 hour, and a significant shorter duration, 2 hours versus the 4. Because the glinides and sulfonylureas have the same mechanism of action, netiglinide, like repaglinide, will not be effective in patients who have not responded to a sulfonylurea. Netiglinide undergoes extensive metabolism by cytochrome P450 enzymes, followed by the rapid and complete excretion, primarily in the urine. So its preparation, dosage, and administration. Starlix is available in 60 and 120 milligram tablets. Initial dose is 120 milligrams 3 times a day, taken again just before meals or 30 minutes before a meal. For patients with an A1C concentration close to the target value, the initial dosage is lower, only 60 milligrams 3 times a day, again taken 0 to 30 minutes before a meal. Please note that dosing must always be associated with a meal, otherwise it can cause hypoglycemia. Which brings us to glidazones, your thiazolidines, which is a mouthful. I'm going to go with glidazones, or simply TZDs. Reduce glucose levels primarily by decreasing insulin resistance. These drugs are not related chemically or functionally to sulfonylureas or biguanides. Their only indication for type 2 diabetes is mainly as an add-on to metformin. The glidazones have a troubled past and an uncertain future. Medications such as rosiglitazone and pioglitazone came under scrutiny for their association with myocardial infarction and sudden cardiac death, and hence are currently available only under a restricted access program. However, the FDA is considering lifting these restrictions, which leaves pioglitazone as the last TZD on the market. Accordingly, it will focus on our discussion about these drugs. Pioglitazone, its action and use, reduces insulin resistance and may also decrease glucose production. The underlying mechanism is activation of a specific receptor type in the nucleus, known as the peroxisome proliferator, activated receptor gamma, or PPAR gamma. By activating PPAR gamma, pioglitazone turns on insulin responsive genes that help regulate carbohydrate and lipid metabolism. As a result, cellular responses to insulin are increased, thereby promoting increased glucose uptake by skeletal muscle and adipose cells, and decreased glucose production by the liver. Because pioglitazone enhances responses to insulin, insulin must be present for the drug to work. Pioglitazone is approved as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes. The drug can be used as monotherapy, but is usually combined with metformin, a sulfonylurea, and or supplemental insulin. Because insulin is required for pioglitazone to work, the drug is not effective in patients with type 1 diabetes. Its pharmacokinetics. Pioglitazone is well absorbed from the GI tract. Blood levels peak about 2 hours after dosing. Food slows absorption. Blood levels peak 3 to 4 hours after dosing, but does not reduce the extent of absorption. Pioglitazone undergoes conversion to active and inactive metabolites, mainly by the CYP2C8. Metabolites and parent drug are excreted in the feces and urine. The half-life of pioglitazone and its metabolites are 3 to 7 hours and 16 to 24 hours respectively. Adverse effects. Pioglitazone is generally well tolerated. The most common reaction are upper respiratory tract infection, headache, sinuses, and myalgia. However, like most drugs, it has a black box warning. Pioglitazone is associated with heart failure, secondary to renal retention of fluid. If heart failure is diagnosed, this medication should be discontinued or used in a reduced dosage. Although heart failure can precipitate for most patients, fluid retention is not clinically significant. However, for patients with heart failure, especially severe or uncompensated heart failure, increased fluid retention can make heart failure worse. In these individuals, fluid retention is exacerbated when pioglitazone is used in combination with insulin therapy. Accordingly, pioglitazone should be used with caution in patients with mild heart failure and should be avoided by those with severe failure. Patients should be informed about signs of heart failure, eudyspnea, edema, fatigue, rapid weight gain, and instructed to consult their prescriber immediately if these develop. Unlike rosiglitazone, pioglitazone has not been associated with MIs. Although TZDs have a low risk for hypoglycemia, when used as monotherapy, the risk is increased when pioglitazone is combined with insulin or with drugs that inhibit pioglitazone metabolism. Use these combinations with severe caution. Pioglitazone can cause ovulation in anovulation premenopausal women, thereby posing a risk for unintended pregnancy. This effect has not been studied in clinical trials, and therefore the incidence is unknown. Women should be informed about potential for ovulation and educated about contraceptive options. Post-marketing data indicate an increased risk for bladder cancer, associated mainly with long-term high-dose pioglitazone therapy. Package labeling warns against using pioglitazone in patients with active bladder cancer or with a history of bladder cancer. Patients should be informed about signs of bladder cancer, blood and urine, worsening urinary urgency, painful urination, and instructed to contact their prescriber if these develop. Pioglitazone appears to increase the risk for fractures in women, but not in men. Most fractures have occurred in the foot, hand, or upper arm, not the spine. Risk appears greater with long-term high-dose therapy. Fracture risk can be reduced through measures to maintain bone health. Among these are exercise, assuring adequate intake of calcium and vitamin D, and, if indicated, use of drugs for osteoporosis. Although pioglitazone has been associated with rare cases of hepatic failure, a causal relationship has not been established. Nonetheless, serum alanine aminotransferase, or ALT, a marker for liver function, should be measured at baseline and periodically thereafter, every 3 to 6 months. If ALT levels rise to more than 3 times the upper limit of normal, or if jaundice develops, pioglitazone should be withdrawn. Patients should be informed about symptoms of liver injury, nausea, vomiting, abdominal pain, fatigue, anorexia, and dark urine, as well as jaundice, and instructed to notify the prescriber if these develop. Pioglitazone has mixed effects on plasma lipids. One effect, the elevation of LDL cholesterol, increases cardiovascular risk. Two other effects, elevation of HDL cholesterol and reduction of triglycerides, reduce cardiovascular risk. The net effect appears to either be a reduction in cardiovascular risk or at worst, and no increase in cardiovascular risk. The heart failure risk mentioned previously must not be overlooked, however. So, drug interactions. Like pioglitazone, insulin promotes fluid retention, and therefore the combination poses an increased risk for heart failure. Accordingly, using pioglitazone and insulin together should be done with caution. Drugs that induce or inhibit the CYP2C8 can alter pioglitazone levels and can thereby alter the glycemic response. Strong inhibitors of CYP2C8, such as atorvastatin and ketoconazole, can increase pioglitazone levels and prolong its half-life, necessitating a reduction in pioglitazone doses. Conversely, strong inducers of CYP2C8, such as rivampin and cimetidine, can reduce pioglitazone levels and shorten its half-life, necessitating an increase in dosage. So its doses are available in 15, 30, and 45 milligram tablets. The initial dose for monotherapy is 15 or 30 milligrams once a day, taken with or without food. The maximal dose is 45 milligrams once a day for patients not using insulin, but only 30 milligrams for once a day for patients who do use insulin. Bringing us to the next medicine, rosiglitazone, also known as Avandia. Similar to pioglitazone, it is indicated for the treatment of type 2 diabetes. It is available in 2, 4, and 8 milligram tablets. The usual dose is 4 to 8 milligrams per day. Rosiglitazone should be used with caution in patients with hepatic impairment. The provider should monitor liver function tests periodically. Your alpha-glucoside inhibitors, which are your carbose and miglatol, act in the intestine to delay absorption of carbohydrates. These drugs are indicated again for type 2 diabetes. Starting with the first, acarbose. Acarbose, or precose, delays absorption of dietary carbs and thereby reduces the rise in blood glucose after a meal. It's to be absorbed. Oligosaccharides and complex carbohydrates must be broken down to monosaccharides by alpha-glucosides, an enzyme located on the brush border of cells that line the intestine. Acarbose inhibits this enzyme and thereby slows digestion of carbohydrates, which reduces the postprandial rise in blood glucose. Its therapeutic use. Acarbose is indicated for patients with type 2 diabetes in conjunction with a program of diet modification and exercise. The drug may be used alone or in combination with insulin, metformin, or a sulfonylurea. In clinical trials, 24-hour weeks of therapy with acarbose alone reduced a mean peak postprandial glucose levels by 57 milligrams per deciliter. compared with a 71 mg per deciliter for tolbutamide alone and 85 mg per deciliter for icarbose plus tolbutamide. In addition to lowering glucose levels after a meal, acarbose lowers A1C levels, indicating an overall improvement in glycemic control. Its pharmacokinetics. Acarbose is administered by mouth, and only 2% is absorbed as an active drug. As a result, systemic effects are minimal. Because acarbose acts locally in the intestine, lack of absorption is considered beneficial. In the gut, acarbose is converted to inactive products by bacteria and digestive enzymes. All good things, though, come with adverse effects, and acarbose frequently causes gas, cramps, abdominal distension, borborygmus, and diarrhea. These responses result from bacterial fermentation of unabsorbed carbs in the colon. Because of the common occurrence of these GI-related side effects, this class of medication is not often used in the US. In addition to its GI effects, acarbose can decrease absorption of iron, thereby posing a risk for anemia. Hypoglycemia does not occur with acarbose alone, but again may develop when acarbose is combined with insulin or sulfonylurea. When hypoglycemia develops, sucrose cannot be used for oral therapy because acarbose will impede its hydrolysis and thereby delay absorption. Accordingly, in patients taking acarbose, oral therapy of hypoglycemia must be accomplished with glucose itself. Long-term high-dose therapy may cause liver dysfunction, asymptomatic elevation of plasma transaminases occur in about 15% of patients. However, overt jaundice is rare. Liver function tests should still be monitored every 3 months for the first year and periodically thereafter. Liver dysfunction reverses when acarbose is discontinued. Its preparation, dosage, and administration. Acarbose is available in 25, 50, and 100 milligrams to be taken with the first bite of a main meal. The recommended initial dose is 25 milligrams 3 times a day, and depending on the tolerability of postprandial blood glucose levels, the dosage may be increased at 4 to 8 weeks intervals. The maximal dosage is 50 milligrams 3 times a day and 100 milligrams 3 times a day for a patient weighing more than 60 kilos. Miglatol, or glycid, which is a second alpha-glucosidase inhibitor approved in the US. Like acarbose, miglatol delays conversion of oligosaccharides and complex carbohydrates to glucose and other monosaccharides, and thereby reduces the postprandial rise in blood glucose. In clinical trials, the drug was especially efficient in Latinos and African Americans. Hypoglycemia does not occur with miglatol monotherapy, but may occur if the drug is combined with insulin or sulfonylurea. Like acarbose, miglatol causes flatulence, abdominal discomfort, and other GI effects. In contrast to acarbose, miglatol has not been associated with any kind of liver dysfunction. As with acarbose therapy, oral sucrose cannot be used to treat hypoglycemia. Rather, oral glucose must be given. Miglatol is available also in 25, 50, and 100 milligram tablets. Again, the initial dose is 25 milligrams 3 times a day before a meal. Your maintenance dosage is anywhere between 50 or 100 milligrams 3 times a day. Which brings us to our dipeptidyl peptidase 4 inhibitors, your gliptins. Your DPP-4 inhibitors promote glycemic control by enhancing the actions of incretin hormones. Reduction in A1C are modest. Hypoglycemia is uncommon when these drugs are used alone. Pancreatitis and severe hypersensitivity reactions occur rarely. The ADA considers the DPP-4 inhibitors to be an optimal second-line therapy as an add-on to metformin in the treatment of type 2 diabetes. When added to the regimen, the resulting decrease in A1C is about 0.5%. However, for some patients, even this small improvement can be clinically significant. So we'll start with the first one, sitagliptin, also known as Januvia. Januvia enhances the actions of incretin hormones, endogenous compounds that stimulate glucose-dependent release of insulin and suppress postprandial release of glucagon. Both of these actions help keep blood glucose from climbing too high. So, how does Januvia boost incretin action? It inhibits DPP4, an enzyme that inactivates the incretin hormones. As discussed, another class of drugs, GLP-1 receptor agonists, also boost incretin actions, but by a different mechanism. Rather than preventing incretin breakdown, they mimic incretin actions. Therapeutic use. Sitagliptin is indicated for type 2 diabetes, either as monotherapy or combined with another anti-diabetic drug. Like all the other agents for managing diabetes, sitagliptin should be used as an adjunct to diet and exercise. Its pharmacokinetics. Sitagliptin undergoes rapid and nearly complete absorption, both in the presence and absence of food. Blood levels peak in 1 to 4 hours after dosing. Most of the drug is excreted unchanged in urine. The elimination half-life is about 12 hours. It also comes with some side effects. Sitagliptin is generally well tolerated. In clinical trials, the most common side effect were upper respiratory infections, headaches, and inflammation of the nasal passage and throat, at rates similar to be seen with placebo. The incidence of hypoglycemia was 1.2% compared with the 0.9% with a placebo, against a non-significant difference. Rarely, patients have developed pancreatitis, including fatal hemorrhagic or necrotizing pancreatitis, according to post-marketing reports. Patients should be informed about the signs and symptoms of pancreatitis, severe and persistent abdominal pain with or without food, and instructed to stop sitagliptin immediately. If pancreatitis is confirmed, sitagliptin should not be resumed. We don't know if the patient with a history of pancreatitis are at risk, although the FDA recommends cautious use if these agents are in the patient. There have been post-marketing reports of more serious hypersensitivity reactions, including anaphylaxis, angioedema, and Stevens-Johnson syndrome. However, the causal relationship has not been established. Nonetheless, if hypersensitivity reaction is suspected, sitagliptin should be discontinued. Sitagliptin has no known clinical relevant drug interactions and no contraindications, including pregnancy. Its preparation, therefore, is supplied in a film-coated 25, 50, or 100 mg dose. The usual dosage is 100 mg once daily, taken with or without food. Because sitagliptin is eliminated primarily by renal excretion, dosage should be reduced in patients with renal impairment, as indicated by the reduced creatinine clearance. Dosage should be reduced to 50 mg once daily or 25 mg in severe renal disease. Taking us to saxagliptin. Similar to sitagliptin, saxagliptin is a DPP4 inhibitor indicated as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes. Saxagliptin may be used as monotherapy or combined with other anti-diabetic agents. It is well tolerated as a pharmacokinetic, both in the presence and absence of food. Your plasma levels peak about 2 hours after dosing. Saxagliptin undergoes a conversion to an active metabolite by the CYP3A4 and 5 isoenzymes. Parent drug and metabolite are both excreted in the urine and feces. To avoid toxicity, dosage should be reduced in patients taking strong CYP3A4 and 5 inhibitors, and in those with significant renal impairment. Adverse effects. In clinical trials, the most common adverse effect were again upper respiratory infections, UTIs, and headaches. Saxagliptin can intensify hypoglycemia caused by a sulfonylurea, but causes little or no hypoglycemia when used alone. Like sitagliptin, saxagliptin has been associated with rare cases of pancreatitis and severe hypersensitivity reactions. If symptoms of either develop, saxagliptin should be withdrawn. Its preparation, dosage, and administration. Saxagliptin is supplied in 2.5 and 5 milligrams for dosing once daily without regard to meals. The usual daily dosage is 5 milligrams. In patients with mild to moderate renal impairment or in those taking a strong inhibitor of the CYP3A4/5, dosage is reduced to the 2.5. Linagliptin. Actions and therapeutic use. Linagliptin, or Tradjenta, is indicated as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes. As with any of the other gliptins, the benefits, which are modest, derive from preserving incretins through the inhibition of the DPP4. Its pharmacokinetics: about 30% of each dose is absorbed both in the presence and absence of food, with peak plasma levels at 1.5 hours after dosing. Linagliptin undergoes minimal metabolism. Most of the drug, about 90%, is excreted unchanged, about 80% in the feces and 5% in the urine. It does have an effective half-life of about 12 hours. Its adverse effects. Linagliptin is generally well tolerated. The drug has caused hypoglycemia when combined with metformin or sulfonylurea, but not when used alone or when used combined with just metformin or pioglitazone. Like sitagliptin and saxagliptin, linagliptin has been associated with rare cases of pancreatitis and hypersensitivity reactions. Again, if either of these develop, the medication should be withdrawn. Drug interactions. Linagliptin is a substrate for P-glycoprotein, a transporter that promotes the excretion of linagliptin and other drugs. In theory, drugs that induce P-glycoprotein could reduce levels of linagliptin. Accordingly, the manufacturer recommends that linagliptin not be used with rivampin and any other P-glycoprotein inducers. Its preparation is supplied in 5 milligram doses or tablets, and dosage is 5 milligrams once a day, taken with or without food. Unlike dosing with saxagliptin or sitagliptin, dosage needn't be reduced in patients with renal impairment. Allogliptin. Allogliptin, or Nesina, is indicated as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes. Again, as with other DPP4 inhibitors, allogliptin improves glycemic control by allowing natural incretin hormones to carry out the glucoregulatory function for a longer period of time. Its pharmacokinetics. The absolute bioavailability of allogliptin is approximately 100% when administered orally. Allogliptin does not undergo extensive metabolism, with the majority of an oral dose excreted unchanged in the urine. Accordingly, this drug is dose adjusted when used in people with renal impairment, as outlined later. Allogliptin has a terminal half-life of about 20 hours and thus can be administered once daily. Its adverse effects. As with other DPP4 inhibitors, allogliptin is generally well tolerated. The most common side effects reported in clinical trials include upper respiratory tract infections and nasopharyngitis. Again, the other agents in this class, hypersensitivity reactions and post-marketing reports of pancreatitis, have been noted. Allogliptin is primarily excreted renally. yet no significant drug-to-drug interactions have been noted, with other drugs excreted through the kidneys. Alogliptin is supplied in 6.25, 12.5, and 25 milligram tablets. The dosage is 25 milligrams once daily. Again, the dose is adjusted based on kidney function, and the recommended dose for 12.5 milligrams daily for people with moderate renal impairment and 6.25 with those with significant impairment. Leading us to a sodium glucose cotransporter 2 inhibitor. The kidneys play a major role in glucose homeostasis, owing to its role in the filtration and reabsorption of glucose in the renal tubules. The transport of glucose from the tubule into the tubular epithelial cells is accomplished by SGLTs. SGLT2 is high capacity, low affinity transporter expressed chiefly in the kidney that accounts for about 90% of glucose reabsorption in the kidney. SGLT2 inhibitors have been shown to block the reabsorption of filtered glucose, leading to glucosuria. This mechanism of action has proved clinically useful in patients with type 2 diabetes in terms of improving glycemic control. In addition, the glucosuria associated with SGLT2 inhibition is associated with caloric loss, thus providing a potential benefit of weight loss. Although currently approved agents hold an indication for the management of type 2 diabetes only, these agents are being studied and used off-label in people with type 1 diabetes. Canagliflozin. Canagliflozin was the first SGLT2 inhibitor approved in the US. By inhibiting SGLT2 in the kidneys, canagliflozin reduces the reabsorption of glucose, thereby increasing urinary glucose excretion. Clinical studies of canagliflozin have shown benefits in terms of improved glycemic control and weight loss. So its pharmacokinetics. The half-life is about 12 hours when taken orally, and thus it can be administered once daily. Peak plasma concentrations are reached within 1 to 2 hours after given a dose. Its adverse effects. The most common side effect noted in the clinical trials were female genital fungal infections, UTIs, and increased urination. Because the SGLT2 inhibitor increased the amount of sugar present in the urine, the increased risk for such infections is not much of a surprise. In addition, particularly in older adults, the use of canagliflozin can lead to post-ural hypotension and dizziness, particularly if used in combination with a diuretic. Drug interactions. Co-administration of canagliflozin with UDP glucouranosyl inducers, so your rivampin, phenytoin, and phenobarbital, can decrease canagliflozin efficacy. Accordingly, if used with such an agent, a 300 mg canagliflozin dose should be considered. Because canagliflozin causes a diuretic effect, the risk for dehydration and hypotension may be increased when used in a combination with a thiazide or loop diuretic. So, its preparation, dose, and administration. Canagliflozin is available as 100 and 300 mg tablets. Canagliflozin is recommended at a starting dose of 100 mg daily, taken before the first meal of the day. The dose can be increased to 300 mg once daily, requiring additional glycemic control and an estimated GFR of 60 ml per minute per 1.73 m squared or greater. Because SGLT2 inhibitors don't work as well in people with compromised kidney function, canagliflozin is not recommended for people with an estimated GFR of 45 or below. That takes us to dapagliflozin. Dapagliflozin, or Farxiga, was the second SGLT2 inhibitor approved in the US in 2014. By inhibiting SGLT2, dapagliflozin suppresses glucose reuptake from tubular urine and thereby increases urinary glucose excretion. As a result, blood levels of glucose decline and weight loss can be seen. Pharmacokinetics: the half-life of dapagliflozin after an oral administration is about 13 hours, and thus can be taken once daily. Its adverse effects: the most common side effects noted with dapagliflozin in clinical studies were vulvovaginitis and other genital infections, back pain, polyuria, and an increased hematocrit. Orthostasis is possible. Its drug interactions induces a diuretic effect in the kidney. The risk for dehydration and hypotension may increase when used in combination with a thiazide and loop diuretic. When used with other antidiabetic agents, patients should also monitor carefully to avoid the possibility of hypoglycemia. Preparation, dosage, and administration. Dapagliflozin is available in 5 and 10 milligram tablets. It is dosed initially at 5 milligrams once daily in the morning with or without food. The dose can be subsequently increased to 10 milligrams once daily if needed to achieve the desired glycemic control. Again, because SGLT2 inhibitors do not work as well in people with diminished kidney function, dapagliflozin is not recommended for people with a GFR less than 60. Which takes us to empagliflozin, also known as Jardiance, which is approved as an adjunct to diet and exercise in the treatment of type 2 diabetes. Similar to dapagliflozin, Jardiance inhibits SGLT2, therefore suppressing glucose reuptake from tubular urine. The half-life of Jardiance after oral administration is about 13 hours, so it can be taken once daily. The most common side effects to Jardiance in clinical studies were vulvovaginitis and other genital infections, including back pain, polyuria, and also an increased hematocrit. Orthostasis, particularly if used with diuretics, is also possible. Drug interactions. Because empagliflozin, or Jardiance, induces a diuretic effect in the kidney, the risk for dehydration and hypotension may be increased when used in combination with a thiazide and loop diuretic. When used with other antidiabetic agents, patients should monitor carefully to avoid the possibility of hypoglycemia. Its preparation, therefore, is available as 10 and 25 milligram tablets. Its initial dose is 10 milligrams once daily in the morning with or without food. The dose can be increased to 25 milligrams once daily if needed to achieve the desired glycemic control. Again, the medication does not work well in people with a diminished kidney function, and their recommendation is not to use it if the GFR is less than 45. Bringing us to cholecephalam. Cholecephalam, or Velcol, is best known as a bile acid sequestrant used to lower plasma cholesterol. However, the drug can also help lower blood glucose. In 2008, the FDA approved cholecephalam to treat type 2 diabetes. Because many patients with diabetes also have high cholesterol, a drug with the potential to treat both disorders was welcome. The pharmacology of cholecephalam is discussed in Chapter 42. Bromocriptine, marketed as Cyclosat, is now approved as an adjunct to diet and exercise to treat type 2 diabetes. The same drug, marketed as Parlodil, has been available for years to treat Parkinson's, which was discussed in Chapter 17, and hyperprolactinemia. In patients with diabetes, bromocriptine may be used as a monotherapy or combined with metformin, sulfonylurea, or other oral antidiabetic drugs. Combined with the use of insulin has not been studied, unfortunately. Benefits in diabetes are modest. A typical reduction in A1C is only 0.5%. So how does bromocriptine improve glycemic control? The mechanism is unclear. We do not know how bromocriptine is a dopamine agonist that can activate dopamine receptors in the brain. By activating these receptors in the hypothalamus, the drug may reverse an abnormal hypothalamic drive that raises plasma levels of glucose, triglycerides, and free fatty acids in insulin-resistant patients. We also know that by activating these receptors, bromocriptine can reset circadian rhythms in people with type 2 diabetes. This action, in turn, may reverse some of the metabolic changes associated with insulin resistance. Principal adverse effects are nausea, drowsiness, and orthostatic hypotension, which can cause dizziness and fainting. Bromocriptine can also exacerbate psychosis. Of note, the drug appears devoid of cardiovascular toxicity. For treatment of diabetes, bromocriptine or cyclosid is available in 0.8 mg tablets, which should be taken with food to decrease GI side effects. Dosing is done once daily, within 2 hours of waking in the morning. The daily dosage is 0.8 mg initially and then increased by another 0.8 mg each week until the maximal dose is reached of 4.8 mg, or until side effects become intolerable. Although approved, this medication is used very rarely in the treatment of type 2 diabetes. So, oral combo products. As noted previously, many patients with type 2 diabetes must take several medications with complementary mechanisms of action to meet glycemic control. Accordingly, to help minimize the number of pills the patient must take on a daily basis, several oral combination products are commercially available. Because metformin is a recommended first-line agent in combination with lifestyle interventions, most combination products contain metformin, with a second antidiabetic agent. The following table shows a combination product available in the United States. Keep in mind, however, that combination products have drawbacks. First, they are often more expensive than taking the components separately, and secondly, they limit dosing flexibility. So here's a good spot to hit pause if you're unfamiliar with all the different types of combo drugs. Your non-insulin injectable agents. In addition to insulin, we now have two additional classes of injectable agents available for the treatment of diabetes. In the amylin mimetic class, pramlintide, the only amylin mimetic currently on the market, is indicated for type 1 and type 2 diabetes. The other class of drug, a GLP-1 receptor agonist, is indicated for type 2 diabetes only. Yet these drugs are increasingly being used off-label for people with type 1 diabetes. Because all of these agents are injectable, they are often mistaken for insulin products, but they work very differently than insulin. So, the first being the glucagon-like peptide 1 receptor agonists. Your GLP-1 receptor agonists, often referred to as incretin mimetics, work by augmenting the effects of incretin hormone GLP-1. Under psychological conditions, GLP-1 and other incretins are released from cells of the GI tract after a meal. Incretin mimetics activate receptors for GLP-1 and thereby cause the same effects as endogenous incretins. That is, they slow gastric emptying, stimulate glucose-dependent release of insulin, inhibit postprandial release of glucagon, and suppress appetite. Owing to augmentation of these effects, incretin mimetics are effective in improving glucose control and can induce weight loss. You will recall that DPP-4 inhibitors boost the effects of incretin hormones by slowing their degradation by the enzyme DPP-4. GLP-1 receptors agonists, in contrast, are structurally related to the native GLP-1 hormone, but are resistant to metabolism by DPP-4. There are currently 6 GLP-1 receptor agonists products approved in the US, with multiple other agents currently in development. So, the first being exenatide, or Byetta, which was the first incretin mimetic. The drug is used to improve glucose control in patients with type 2 diabetes. A longer-acting formulation of exenatide, known as exenatide once weekly, is currently available and is dosed once weekly. Nausea is common, and hypoglycemia can occur, particularly if used in combination with a sulfonylurea. Description and action. Exenatide is a synthetic analog of GLP-1, a peptide hormone in the incretin family. Exenatide activates receptors for GLP-1 and thereby causes the same effects as endogenous incretins. That is, it slows gastric emptying, stimulates glucose-dependent release of insulin, inhibits postprandial release of glucagon, and suppresses appetite. Its therapeutic use is indicated as adjunctive therapy to improve glycemic control in patients with type 2 diabetes. In clinical trials, a subcu injection of exenatide 5 or 10 micrograms twice daily before the two largest meals of the day produced a modest decrease in fasting blood glucose and a large decrease in postprandial blood glucose. Patients did not gain any weight, and many lost weight. In contrast, exenatide ER for injection or injectable suspension, 2 milligrams by sub-Q injection once weekly, has a greater effect on fasting glucose as opposed to postprandial blood glucose. These differences are related to the varying pharmacokinetic profiles of the two products. So, speaking of, Byetta, the plasma levels peak 2.1 hours after sub-Q injection and decline with a half-life of 2.4 hours. Exenatide ER suspension, in contrast, is released slowly from microspheres over approximately 10 weeks, with a peak level of drug reached at about 2 weeks after administration. Exenatide is excreted unchanged in the urine. In patients with mild to moderate renal impairment, clearance is reduced only slightly, and therefore no dosage reduction is needed. In contrast, in patients with end-stage renal disease, clearance is reduced significantly, and the drug should not be used. Adverse effects. Dose-related hypoglycemia is common when exenatide is combined with a sulfonylurea. To minimize hypoglycemia, sulfonylurea dosage may need a reduction. Your gastrointestinal effects, your nausea, vomiting, and diarrhea are common in exenatide. Exenatide ER suspension is better tolerated in terms of nausea and vomiting, but can result in injection site irritation and pruritus. In some patients, anti-exenatide antibodies develop. These antibodies do not cause adverse effects, but they can reduce exenatide's effects. Exenatide poses a risk for pancreatitis. Severe cases had led to a pancreatic necrosis, pancreatic hemorrhage, and even death. Patients should be informed about the signs and symptoms of pancreatitis, typically severe and persistent abdominal pain with or without vomiting, and instructed to stop the medication immediately. If pancreatitis is confirmed, exenatide should not be resumed. Patients with a history of pancreatitis should not use this medication. Exenatide can cause renal impairment, sometimes requiring hemodialysis or a kidney transplant. Fortunately, the incidence is low, only one case in about 13,000 patients. Risk for renal impairment may be increased by nausea, vomiting, and diarrhea, and any other event that can cause dehydration. Exenatide should be avoided in patients with severe renal impairment and should be used with caution in kidney transplant recipients. In pregnant animals, doses of exenatide only 3 times the human dose caused fetal harm, manifesting as reduced growth and skeletal abnormalities. At this time, the drug is classified as the FDA Pregnancy Risk Category C and should only be used if the benefits outweigh the fatal risk. Furthermore, given the established safety and efficacy of insulin in pregnancy, there seems to be very little reason to even try exenatide. There have been post-marketing reports of serious hypersensitivity reactions, which include anaphylaxis and angioedema. If severe reactions occur, patients should stop taking the medication and seek immediate medical attention. Its drug interactions. Exenatide delays gastric emptying and hence can slow the absorption of oral drugs, thereby decreasing plasma levels and prolonging the time to peak serum levels. Reduced absorption is of particular concern with oral contraceptives and antibiotics, which require high peak concentrations to be maximally effective. To minimize this interaction, give oral drugs at least 1 hour before exenatide. Its preparation, therefore, is supplied in prefilled 60-dose injector pens that deliver 5 or 10 microgram per dose. Subcu injections are made into the thigh, abdomen, or upper arm. The initial dosage is 5 micrograms twice daily, administered 0 to 60 minutes before the morning and evening meals. Never after the meal. After 1 month, the dose may be increased to 10 micrograms twice daily. If the patient is taking a sulfonylurea, its dosage may need reduction. If the patient is taking metformin, no dosage reduction is needed. Because of greatly reduced clearance, exenatide should not be used in patients with severe renal impairment. The extended release is supplied in 2 milligrams powder in a single dose vial or pen for suspension in a diluent for injection. The subcu injections are made into the thigh, abdomen, or upper arm. Liraglutide. Liraglutide is an incretin mimetic similar to exenatide. This drug is indicated as an adjunct to diet and exercise to enhance glycemic control in adults with type 2 diabetes. Like exenatide, liraglutide is an analog of human GLP-1 that causes direct activation of GLP-1 receptors and thereby slows gastric emptying, stimulates glucose-dependent insulin release, and inhibits postprandial release of glucagon. Liraglutide is more convenient than exenatide. Dosing is done just once a day, without regard to any meals, rather than twice a day before meals. Liraglutide can be used alone or combined with any other antidiabetic drug. Most often the drug is combined with metformin, a sulfonylurea, or other agent. Because sulfonylureas actively drive down blood glucose levels, adding liraglutide to a sulfonylurea regimen increases the risk for hypoglycemia. Reducing sulfonylurea dosage at the start of liraglutide treatment seems to lower this risk. Liraglutide has been shown effective as an add-on to rosiglitazone, a drug that is all but gone from use. Although liraglutide has not been studied as an add-on to pioglitazone, it seems likely that liraglutide would be effective with pioglitazone as well. Its pharmacokinetics. Pharmacokinetics of liraglutide are unremarkable. Plasma levels peak at 8 to 13 hours after subcu dosing. The drug undergoes metabolic breakdown, followed by excretion in the urine and feces. The plasma half-life is 13 hours long to permit a once-a-day dosing. Its adverse effects are dose-related and our GI effects are common, developing in almost 41% of patients. Specific effects include nausea, diarrhea, and constipation. Hypoglycemia can also occur, especially when combined with sulfonylurea. In clinical trials, 8.6% of patients developed anti-liraglutide antibodies. This is surprising given that liraglutide is nearly identical to human GLP-1 and therefore should not be antigenic. In theory, these antibodies could neutralize liraglutide. However, to date, there is no evidence that this has happened. Like exenatide, liraglutide has been associated with rare cases of pancreatitis. Again, if pancreatitis is suspected, liraglutide should be discontinued immediately. If pancreatitis is confirmed, the drug should never be used again. However, if pancreatitis is ruled out, the use of liraglutide may resume. Like exenatide, liraglutide has been associated with rare cases of renal impairment. Most cases occurred in patients who had experienced nausea, vomiting, or diarrhea, or any other event that can cause dehydration. Renal impairment may reverse with supportive treatment and discontinuation of liraglutide and any other potential causative agents. There is concern that liraglutide may cause thyroid C-cell tumors, including medullary thyroid carcinoma. In tests on rodents, clinically relevant doses have caused C-cell tumors. However, there's no proof that liraglutide has caused these tumors in humans. So it's black box warning. Again, it has been associated with the development of the thyroid C-cell cancer. The drug is contraindicated with patients who have a family history of MTC and in those with multiple endocrine neoplasm syndrome type 2 or MENS 2. Drug interaction, as noted, combined with a sulfonylurea, can increase the risk for hypoglycemia. Dosage of the sulfonylurea may need a reduction. Because liraglutide delays gastric emptying, it might delay the absorption of some oral drugs, thereby reducing their peak serum levels and prolonging the time to peak serum levels. Preparation, dosage, and administration. Liraglutide is supplied in prefilled multi-dose injector pens that deliver 0.6, 1.2, and 1.8 milligram doses. Administration again is subcutaneous into the abdomen, thigh, or upper arm. Dosage is done once a day at any time and independent of meals. The initial dose is 0.6 once a day to minimize GI side effects. After 1 week, the dosage is increased to 1.2 once a day. If that dosage proves inadequate, it can increase to 1.8. Bringing us to Alpha-GLucosidase. I actually mispronounced it. It's Alpha-GLucosidase. Alpha-GLucosidase, or Tansium, is an incretin mimetic indicated as an adjunct to diet and exercise to enhance glycemic control in adults with type 2 diabetes. Like exenatide ER suspension, albiglutide is administered once weekly by subcutaneous injection. The safety and tolerability profile of albiglutide is likewise similar to that of exenatide ER suspension. Your albiglutide is supplied in a single-dose pen for administration of 30 and 50 milligram doses. It is recommended to be initiated at 30 milligrams once weekly. The dose can increase to 50 milligrams once weekly in patients requiring additional glycemic control. Bringing us to dulaglutide. Like albiglutide, dulaglutide is a GLP-1 receptor agonist indicated as an adjunct to diet and exercise to enhance glycemic control in adults with type 2 diabetes. Dulaglutide is administered once weekly by sub-Q injection. The safety and tolerability profile of albiglutide is similar to that of albiglutide. The medication is supplied in a single-dose pen as well as a single-dose prefilled syringe. Both pen and syringe are available in 0.75 and 1.5 milligram per ml solution. Initiation should be started at 0.75 milligrams once weekly and can be doubled in patients that need additional control. Amylin mimetic pramlintide. Your pramlintide is the first member of a new class of anti-diabetic agents, the amylin mimetics. This drug is used to complement the effects of insulin in patients with type 1 or type 2 diabetes. Severe hypoglycemia is a concern, and nausea is common. Pramlintide is a synthetic analog of amylin, a peptide hormone made in the pancreas and co-released with insulin. Both amylin and pramlintide, which mimics the effects of amylin, reduce postprandial levels of glucose, mainly by delaying gastric emptying and suppressing glucagon secretion. In addition, both agents act in the brain to increase the sense of satiety, helping to lower caloric intake. Its therapeutic use is indicated as a supplement to mealtime insulin in patients with type 1 and type 2 diabetes who have failed to achieve glucose control despite optimal insulin therapy. Patients with type 2 diabetes may combine insulin and pramlintide with metformin and or a sulfonylurea In clinical trials, adding sub-Q pramlintide to mealtime insulin doses decreased postprandial glucose levels, smoothed out glucose fluctuations, and reduced the needed mealtime dose of insulin. Mean reductions in A1C were about 0.39% for those with type 1 diabetes and 0.55% of those with type 2. Its pharmacokinetics, therefore. Blood level peaks about 20 minutes after sub-Q injection and decline with a half-life of 49 minutes. Unlike most drugs, pramlintide is metabolized in the kidneys rather than the liver, once active metabolite has been identified. Its adverse effects is hypoglycemia as the biggest concern. Pramlintide does not cause hypoglycemia when used alone, but poses a risk for severe hypoglycemia when combined with insulin, especially in patients with type 1 diabetes. As a rule, hypoglycemia develops within 3 hours of dosing. To reduce risk, insulin dosage must be decreased, at least initially. Also, pramlintide should not be given to patients who have hypoglycemia unawareness, a history of poor adherence to their insulin regimen, poor adherence to their SMBG, or recurrent hypoglycemia needing assistance, leading us to its black box warning. Pramlintide poses a risk for severe hypoglycemia, again when combined with insulin, especially in type 1 diabetes. Nausea occurs early in therapy and is more common in patients with type 1 diabetes than type 2. The incidence and severity of nausea can be reduced by gradual titration of dosage. Injection site reaction, redness, swelling, or itching may occur, but generally resolve within a few days to weeks. Its drug interaction, therefore. By delaying gastric emptying, pramlintide can delay the absorption of oral drugs. Accordingly, oral drugs should be taken 1 hour before injecting pramlintide or 2 hours after. Pramlintide should not be combined with other drugs that slow intestinal motility, such as your antimuscarinic agents, opioid analgesics, or with drugs that slow the absorption of nutrients, your acarbose or miglitol. Its preparation, dose, and administration, therefore. Pramlintide is supplied as pre-filled Symlin pens, which should be stored under refrigeration but not frozen. Pens currently in use, which can be kept cool or at room temperature, should be discarded after 28 days. Dosing is done before major meals that contain at least 250 kilocalories or 30 grams of carbohydrates. Subcutaneous injections are made into the abdomen or thigh. In patients with type 1 diabetes, the initial dose is 15 micrograms before meals. If there are no serious nausea for 3 days, dosage can be increased in 15 microgram steps to a maximum of 60 micrograms. If 30 micrograms causes too much nausea, discontinuation should be considered. In patients with type 2 diabetes, the initial dosage is 60 micrograms before meals. If there are no serious nausea in 3 to 7 days, dosage may be increased to 120 micrograms. In patients with type 1 or type 2 diabetes, the premeal dose of short or rapid-acting insulin should be decreased by 50% to reduce the risk for hypoglycemia. When the maintenance dosage of pramlintide is established, the insulin dosage can be titrated upward as needed to achieve the desired glycemic control. Glucagon for the treatment of severe hypoglycemia. Insulin overdose and use of insulin secretagogue medications can cause severe hypoglycemia. The preferred treatment is IV glucose. However, if this option is not available, blood glucose can be restored with glucagon. Glucagon, a polypeptide hormone produced by alpha cells of the pancreas, has effects on carbohydrate metabolism that are opposite to those of insulin. Specifically, glucagon promotes the breakdown of glycogen to glucose, reduces conversion of glucose to glycogen, and stimulates the biosynthesis of glucose. Hence, Whereas insulin acts to lower plasma glucose, glucagon causes plasma glucose to rise. In addition to these metabolic effects, glucagon acts on GI smooth muscle to promote relaxation. Glucagon is used to treat severe hypoglycemia in the ambulatory setting. However, in patients with severe hypoglycemia, IV glucose is preferred because it raises blood glucose immediately, whereas responses to glucagon are somewhat delayed. Accordingly, glucagon should be used only if IV glucose is not an option, such as a subcutaneous administration in the home setting before emergency services arrive. When IV glucagon is administered to unconscious patients, the subsequent rise in blood glucose usually restores consciousness in 20 minutes or so. When consciousness is sufficient for swallowing, oral carbohydrates should be given. These will help prevent recurrence of hypoglycemia and will help replenish hepatic glycogen stores. Glucagon cannot correct hypoglycemia resulting from starvation. Glucagon acts in large part by promoting glycogen breakdown, and people who are starved have little or no glycogen left. Glucagon is administered parenterally, intramuscularly, subcutaneously, or intravenously. The drug is supplied in powder form and must be reconstituted to a concentration of 1 mg per ml, using the diluent supplied by the manufacturer. A dose of 0.5 to 1 mg is usually effective. And that concludes our chapter for today. I thank you all for listening, and I'll see you at the next chapter. Till then, take care.